LED is coming from, it's very difficult to identify. Having looked through some of these pictures, I think it is probably that large branches and intermediate, and that the LED comes immediately from the left lane. If we go to the caudal view, just go forward on the images, please. So the whole branch has been treated. Go forward. Can you go to the next image to the caudal view? The RCA has been treated, so we might find there are some collaterals that have developed from the RCA. So we're going to take a picture of that and see. And if that is the case, then we should be able to use them, hopefully. Quite often, the collaterals from the right to the LED are the most difficult to kind of navigate or even to engage. Sometimes you see a leash of them and you still can't get through them. The second option is if the LED is where I think it is coming immediately from the left main stand, then we will put a wire into that, what I think is an intermediate, and see if we could see the cab, identify the sponsor cab. The third option, if this is difficult, because often with CTOs and there'll be calcium fibrosis, and if it's difficult to identify where the cab is, then the option is to go retrograde through these epicardial if there's none from the right coronary artery. The epicardial will require special wires like the SOA3 or the Anireach 0.3, which are not available, but I'm hoping that we should be able to identify the cab or use that retrograde in that way. So there's a good chance of succeeding here. Sometimes having the right equipment, the right wire might be the difference between reaching your goal or not, but I'm hoping that we should be able to. But on our side, in a way, is his age, and the arteries look fine. Should be much calcium, but we will explore. And the other option is whether there's some collaterals have developed from the right coronary artery. So this is what we will do. I don't know if anybody has. I suppose we can't hear. We're just going to have to say what we think, right? No comment. Right? Okay. So just take a picture of the right coronary artery and see if we have any collaterals that have developed and whether are usable or not. So take a GR4, I think, and we'll see what happens. Because if there's no collateral from that, we just focus in one. We take a short guiding catheter to the left. In cases like this, I would go for 8 French. So obviously 8 French is not available, so take 7 French. And toward the end, if we went retrograde, we might have to a bing-bong technique. You take a second guide so we could externalize our retrograde. So let's have a look and see. And we have given heparin,
yeah? Yes, we have, yeah. Okay. We have given the 3,000 units of heparin for the diagnosis shot. If you have to puncture the groin, then of course we are leaving allowance rather than the full dose. Yeah.
Okay, so let's have a look and see, and that will decide the next step. So in a way, when you're looking at CTOs, you're kind of escalating with the safest to the more demanding and more, I don't want to say risky because that's not the right word. I do epicardial collaterals almost on a weekly basis, and thankfully, if you handle them rightly and you kind of approach them in the right way, the chance of it causing any problem is very, very limited, but nonetheless, it is there. So obviously for collaterals, if you go in retrograde, the vein grafts are the safer, and this is if somebody wants to start the retrograde, they should try and use vein grafts as a first approach. If not, then the septals are much safer. Correct. They are more forgiving. You could still have a perforation, you could have a dissection. They are more forgiving. There are some rare cases you could have a septal hematoma or even a ventricular wall hematoma and could cause a dry tamponade. Rare, but nonetheless it can happen. And then comes the epicardial. The epicardial is difficult to navigate. If any a little perforation something happens, so it could be difficult to treat. And also because of the tortuosity, the contractility of the myocardium makes the control of the wire difficult. This is where the SOA3 comes in because it's coreless, it doesn't have a core, so it could easily pass through because you just let the wire do the work. So let's have a look and see.
So this is one of the reasons why we are advocating, do using of these treatments that are supposed to be difficult to acquire. I think we should make a case to acquire these things, technology.
Yeah, I think so. Yeah,
it's an important part case to expect.
I mean, you're not going to be using it all the time, but it's when you need to use it, it's there. Yeah.
Read in Ponius Mangan, Mr. Rajapna. Ponius Mangan. Okay. Do LAO, please.
Oh, well, it's way inside. I'm gonna have to change and take this off and put it back on again. You really should do an RAO.
This is the microphone. So we probably should put it on this. So we take the.
Oh, yeah, when you test,
Sector collaterals are there to the LED, but you can also see the calcification and the
Actually,
YouTube channel live thing on.
take two guiding factor and then make such easier.
Yeah.
Well, hopefully, because I said.
You can also take a long shot of the left side also just stick. Yeah,
I think we just do that. There's no point of. Let's take a 7 pencil as well and then you're already doing that anyway. So aim for that one. The setup shots for the CTO are really important.
You can't hear his voice. His mic is inside.
Yeah, that's right. I'm fixing it.
We're just gonna probably might do another video. Just open the PDLC.
residual tapering. Yeah, residual tapering. Weight 60.
Another 5,000.
Another 5,000. 5,000.
We will check the HCT, because when you go with it, that's the most important.
Yeah, so you just play that.
Yeah. Take
Next one.
PA cranial as well, please. Okay.
We'll do it bilateral.
Bilateral.
So we should change this to a guide.
Okay.
Yeah.
Yeah. Yeah. Another 5,000.
Another 5,000. Yes.
Okay.
So let's take a JR4 and AL, whatever. Go back one. Go back.
There's a 260
A blade there. Yeah, a JR4 7 French also.
Yeah, for 7 French.
From the radial, yes.
Yeah. Yeah, for 7 French.
You could do the retrograde 6 French, but I think it's much more because it's a smaller. the chance of thrombosis and problems not. Do you have a Corsair or is it only Caravelle?
Corsair is also available.
Okay,
Caravelle is
fine,
also
right.
available.
Okay, okay.
Yeah.
So we'll go 7 French. Let's just not. Some people do a lot of these procedures 6 French. I always say, if I made the puncture, why do I need to be? It's better to have the space.
Understood,
And, yeah. And the same thing, if you need to put an IVUS, you need to anchor, you need to do different things. It's much easier to have the space.
Yeah, so I think the viewers probably would be getting the gist of what Prof is saying. More space you have, more equipment that you want, more manipulations, and then if you want to externalize a wire, there should be enough space.
Absolutely.
And if you want to tip in,
Absolutely.
using a guideliner, etc., you will have more space. So all these options are being thought of while you are planning the case.
I mean, all what we do as all these procedures is about being pragmatic rather than dogmatic. There's no set rule there's a principle that you follow. But yes, if I'm puncturing the left femoral or the femoral, I might as well, whether 6 French or 7 French, if you do the puncture right, it's not going to matter. If you're going to have a problem, whether it's 5 French or 6 French, or it's probably the same. So we do the puncture properly and. Okay. And let's change also this to guide. Yeah.
Right also needs to have the guide. Right, 7 French to GR 3.5.
Yeah, we need a sheath also, 7 French sheath.
Yeah. Another upgrade with the 7 French sheath, please. Guide. Yeah. GR 3.5.
Do you have a catch for this?
Another line, please. Yeah, another catch, please.
Let's just wait. Let's get the catch. Let's have it in a second. Let's get the catch first. What rate is the fluoro? No, just drop it down to 7.5, please. Change the frame rate to 7.5. To 7.5. Yeah. For screening, okay? And the acquisition at 10 is more than enough. Yeah? So change the acquisition to 10.
Okay. Screening, please. Okay, we'll change over the long wire.
Okay. Let's do that first.
So we are changing over to a 7 French access for the radial after the initial 6 French puncture. To try to get a 7 French guide, anticipating a requirement for retrograde approach.
I think in this case we are going to go straight retrograde because it's very ambiguous. What we might find that if we do the bilateral injection, simultaneous injection, we might find that we might be able to identify where the LED is coming from. But you never know. So let's just be ready for. Take the JR4 guide diagnostic. Sorry, guide. JR4 guide 7 French. That's 7 French, yeah? There you go. Okay. And can we have an ACT? Double check the ACT, please.
Okay, sample for ACT, please. Ready, sir. Screen, please.
So I'm just going to say something about the X-ray because when you're doing all these long cases, you need to minimize your X-ray exposure as much as you can. The wire is in the aorta, right? And this catheter is 100 centimeter. I'll fix the wire. Don't start screening until it's about 30 meter out. The habit is just to keep screening. It's not going to go anywhere, right?
Can you get the screening pedal here?
So the same thing.
Screening ourselves, I think that may be better.
So we're going to use this for the.
Ourselves, that may be better.
Okay.
Yeah.
Let's have the wire now.
Okay.
Let's have the wire.
035 wire, please. Yeah, sure. Okay.
Yeah, let's take it from the sheet before we go.
Before we go, yeah.
Yeah, it's much easier.
Yeah.
So I don't
Flash
like
steering
mess.
sheet, yeah.
I always assemble this, close it, flush it, and then so there's no blood coming back,
Steering sheet.
and the table remains clean
Absolutely.
and tidy. Because okay, let's flush. How do we flush on this? How do I flush?
Flush.
Which one? That one. Okay.
Flush one.
It's not flushing.
Flush one, maybe.
Okay, flush.
Okay, stop the flush, please. Good. That's fine. Stop it.
Okay, stop.
Good. Right. So now we could go in and no bleeding, nothing. It's all
Clean.
good.
Okay.
So that's for the left system. Push the wire out.
Huh? Guide wire. Yeah, but first we'll take some pictures and then decide, okay?
Okay, so let's stop screening now. Yeah, keep going, keep going, keep going, keep going, keep going. Yeah. Now you can start screening. It's bleeding back. Where's your, there's no, what's happening here? Why is this bleeding back? You have to close this or?
Yeah, that's okay.
Okay,
No,
because
we've
it's
got
bleeding.
pressure, yeah. Okay, so let's leave.
Where's the pressure on the other one?
Pressure down, make it.
Where's the pressure on the other one?
Yeah.
No, we only have one pressure
Yeah,
wave,
that's
so
good.
we have.
That's
That's fine. Okay, good, good, thank you.
Flash, please. Sorry, make it flash. Flash. Okay, right.
Right, so setup shots for the CTO is very important.
Yeah.
We're off mag, we open everything up, we set ourselves unlock here.
Okay.
Unlock.
LAO, please, just to check.
Okay,
Yeah.
just engage both.
Yeah.
I need to get used, so I need to open this like this, yeah, and then inject it.
Yeah, that's right, yeah.
Okay, we're almost there. Yeah, that's probably the 3.5, but that's okay.
Nope.
So I might have
Wire,
to do.
wire sharpen, please. Wire sharpen. The sharpen.
Oh, the sharp end, okay.
Yeah.
Yeah.
Just check the position.
So what we could do, take us a wire and just put it into the artery and the guide will fall,
Yeah.
will follow.
Take a cyan blue wire, please. In the meantime, shall we adjust the
Yeah, let's do the right,
please?
yes.
Yeah. Check. Yeah, it's already there. Yeah, that's good. Okay.
Have you noticed anything with the X-ray? Any difference? No.
Slightly, yeah.
Well, it's
Yeah.
because it's 7.5, so it'll give you the same thing.
Yeah, yeah.
Absolutely the same thing.
Yeah, I get your point.
It's especially when you're doing these long cases, and this is for general. I'm not saying, you know.
Yeah.
X-ray, you could step on the pedal, you could do as many X-ray, you don't feel anything, but the accumulative effect is
Yeah.
tremendous. So we have to, minimizing your X-ray exposure is really crucial. So coming down with the frame rate, avoiding, you know, extreme angulation. Okay, that looks okay. Good. Okay, so now we're gonna go to RAO cranial. Let's just do that.
Yeah.
If we are stuck and we're not engaging very well, we might have to take a guideline to the.
Yeah, sure.
And when you're doing the setup shot, you start with the retrograde injection first.
Yeah.
So, and we don't move the table. Unlock the table. Let's screen. Can I have the screen?
Yeah.
Oh, you have it. Okay, that's okay.
Yeah.
So I'm assuming the screen is the left bottom.
That's right. That's fluoro. And
Unlock the table for me. Unlock the table.
Unlock.
Okay, open up. Open everything up. Come off mag.
Off mag.
Come off mag.
Off mag.
Yeah, just no mag. Okay, that's better. Okay. So can you have a little test for me just to make sure that we see, because. Okay, good. So, and the cine is the which one is the cine? The middle one. Right, okay. So, okay, you're gonna start.
Okay, when you're ready.
Don't move the table, please. Do not move the table. Yeah, so I think it's where I think it is. It is.
You can see the calcification down there, you know, where the septal branch comes in joint.
Yeah, we need to get that right, engaged better.
The LED.
There's a lot. No, the right.
Okay.
Because there's a lot of spill and we can't get. The same thing with the.
Yeah.
The same thing with the. Okay, let me press on the right. Okay, and that guide in the left also needs to come up a bit towards. Let's see if we could slide it on top. Test there. Is it engaged?
Check.
Test.
No.
Yeah, we're not engaged. If you lift it up and turn it, it might go properly now. Otherwise, we could take a guideliner, but I don't want to complicate the.
Check. Yeah, that's a little bit. Maybe on this part. Yeah.
So look and see if it'll.
Yeah.
It'll work with this. Yes, I mean he's a big man.
Yeah.
Test me there. Gentle test.
Gentle test.
Yeah, okay. Right, and can we do a, just come to RAO caudal. RAO caudal is the best to see the septals usually.
Yeah.
And obviously there's no set rule, but that's kind of, so. Unlock the table. Can we move this ECG or whatever the cable is in there?
Cable, yeah.
That's coming on top of our city. So yeah, important to make sure the field of view, no magnification. You fix the table, don't move it. Okay. If you move the table, it becomes very difficult to know the laterals, the lengths. And this will tell you how. Okay.
Okay. When you're ready.
There we go.
Okay.
Yeah. Okay. When you're ready.
Okay.
Okay. Go. You go. Yeah, it's difficult to know where it is, but we're gonna have to go retrograde. So at least we could see some laterals there. Where they're coming from, that's a very good question from the right. Okay, can you do a BA cranial?
PA cranial, please.
You can see how ambiguous this anatomy is.
Correct.
It's really very ambiguous. So, okay. And yes, we consume, I'm talking about X-ray, but it's okay to consume some X-ray at the beginning. Let's go.
Saves up a lot of time at the end. Yeah. Oh, okay.
I think it's coming from the left, what I thought it is, but well, okay. This is going to be surfing to find which one takes us. Yeah, absolutely, because they may be very difficult. That tortuosity in the RCA itself, distally, makes accessing these collaterals quite difficult. Go back one. Can we bring this a bit closer forward? Bring it. Keep coming.
Yeah, ventricular topic.
Thank you. It's okay. I mean, it's probably ischemia. Right. So now the question also, is the proximal RCA lesion significant enough? I don't think it may be the wire that's causing that. It's not, actually, it's not in a branch, but anyway, it's okay. Right, so let's have a Corsair Pro 150.
Corsair, please,
150.
Okay, 150 Corsair.
And we'll take, so here,
what wire would you like?
We'll just take we put a safety wire in the RCA. So we could take a cyan blue also in the RCA.
Okay.
150. So put a safety wire in the RCA. And then you take the Corsair with, again, to start with, to access these septals, you're going to have a big bend. Because when you access them, the big bend will not allow you to go through them. So we'll have to change. And this is about using escalation and de-escalation. Each wire will have a task to do. So to access this collateral, we need a big bend.
Correct.
But once we get into them, we'll swap that wire into a different one.
Correct.
Often for the septal or any collaterals, cyan black is probably very, very good wire, or normal cyan.
Yeah.
And then we put a very small bend.
Yeah.
If you have a big bend, if a small bend, you will not access the collaterals. If you have a big bend, you cannot go the collaterals. So each wire will do a task. Once it's done the task, we change it to what we need to be able to do.
Sure.
So, right.
What do we have? 5 plus 150, but not really the greatest.
135 is not enough. Do you have a Caravelle 150?
Caravelle 150, please. Caravelle
Again,
150.
so the Caravelle, in theory, you cannot spin it.
Exactly.
It's not braided. The same with the fine cross.
150. 150.
150.
150 caliber.
Do you have, okay. Do you have a 150 fine cross? We'll just have to ask. Again, the fine cross, you cannot spin it.
Exactly.
It's not,
So
it's
just sitting
spinnable,
there
so you have to accept.
Yeah.
Occasionally, to go from the right to the LED in the distal part to access these collaterals, the easiest way is to do the fine cross because it's a blunt tip, so if the wire hasn't taken. Is this 150 fine cross?
Fine cross is 150, yeah.
Yes.
Okay, let's have it, fine.
Yeah,
Okay,
yeah.
let's just not waste time. Can we have another cyan blue?
Sun blue, please, yeah.
To put it in the
Go
artery
with
as
the,
a...
with the microcat.
No, to put it in the as a safety wire.
Sure.
Because we have a stent, we have just in case anything happens, we need to have access to the
Oh, okay.
Yes,
Yeah,
please.
come on. Sure.
cyan blue. So
Yeah.
we'll put it down and we'll take. I suppose we could use it to access the collateral first,
Correct, yeah.
and then we could leave it back as. Yeah, 150, please.
Yeah.
Open that up. Yes. So I would make a small tip and then a big elbow at the back.
Yeah.
About 2 millimeters, so you could access these. Flush it from the outside. Oh, before you take it, flush it from the outside first because it's all hydrophilic to activate the coating.
So show the viewers, what we are doing, because it's educational.
So
process
whenever
work.
they come, this is why you flush it from the outside first, and because if it's not, we need some more saline.
Some more saline, please.
Yes.
Okay, saline first.
Okay, and now we flush the inside. If you move it, and that's good. Okay. So let's just add, let's just put this on top of the.
Sure.
Let's just put it on top of the fine cross.
Actually, just put the wire through it, first,
Yeah,
and then
yeah.
before we advance it. That's what I was thinking.
Makes life easier.
Yeah, exactly.
There's the
Yeah.
tip.
Tip is already.
Sorry, no, keep it, and don't take it out.
Okay.
Don't take it out. You just take the needle out. Okay.
Okay.
What's beeping? What's wrong? And 150, of course, because 135 will not reach. You're going through through
Yeah.
collaterals, because we did not use a 90 centimeter guide.
Yeah.
Usually for the retrograde guide, you always need a 90 centimeter. Okay, let's just push this.
Yeah. Okay.
Is that still? Now we're gonna.
No, I think we might have to get the.
Okay, pull the wire back.
Yeah.
Pull the wire back.
Okay.
Pull the wire back.
Pull the wire. Pull the wire.
Pull it back. Just 1 second. Yeah. Pull the wire back. Pull the wire back. Pull. Okay.
Okay, that's good.
Now
Okay, so we can do it with this.
What's the ACT, guys? We've taken ACT.
ACT.
478.
Okay, good, fine.
Sir.
Is it so? We need to repeat it. It's not
Okay.
accurate. It's
Please.
probably contaminated. Then.
478, sir.
RAO.
Fine. Okay.
LAO, sorry, LAO.
That's okay. So no, we're engaged. It's fine.
Okay.
It's fine. It's fine. Stay where you are.
Okay.
Stay where you are. Because we're engaged. The wire will fly. If we have a problem, we could go to. Okay.
Okay.
So take that micro catheter. Don't worry.
Yeah.
Let's take it. That's it. So I was saying that, will we have any problem with that? I don't think we will have any problem with the proximal part. Okay. Unlock the table for me. Okay. Just take the micro catheter.
Okay. Hold the wire.
Yeah, I'm gonna hold the wire here. Slowly. Where are we? Okay. Now you must it first. So see the tip. 1 second. Just 1 second. Let's just bring the micro catheter back a bit. And that tip is quite huge. Just come back. Go back. Stop for a second. Go back one, please. Go back one. Okay. Let's have a look screening for me. Oh. Let me just bring this micro catheter because it's committing us. Yeah, that's a big bend. That's not as much as we wanted.
Okay. Do you want another wire?
We might have to because.
I think
Let's have a little test and see because that's.
during the reintroduction of the thing,
it's okay.
coming out, it
It's
might
okay.
have pulled out a little bit more. Okay,
Okay.
right, ready?
No, Sunny, just a little test. We don't need to Sunny. Okay. So. It's the stent because you have, I told you, I think it's very undersized. Stent.
Correct.
And whether, okay, just come to LAO.
LAO,
I
please.
think it's undersized, the stent,
Correct.
and we need getting this wire through it. We have a talker, let's just see what's.
I'll get you some guide support, just
Just
engage
get
a
it
little bit more.
inside.
Yeah.
Okay. Yeah, that stent is.
Yeah.
That's you don't want to go behind the stent also.
Correct,
because
yeah.
that's. I think this artery is at least a 335 and 25 is probably under deployed. So here we're going on a loop. I'm not sure. We need to make sure that we're not sub-screening for a second. Okay.
Yeah, I think we have to.
Okay.
Okay.
Let's move this microcatheter slowly.
Yeah.
Let's go forward. Go. Okay.
Yeah.
Is it going?
Yeah, it's going smooth.
Okay.
Yeah.
Let's bring this back gently. I don't know. The wire is really tight. Oh. That's better. Okay.
That's better. Yeah.
Fine.
It's just
Okay,
proximal
back to
fluid.
BA cranium.
Yeah.
We might have to swap this wire anyway because now it's got a loop.
Yeah, that's okay.
Fine. Okay, let's take this microcatheter
A
forward.
little forward, yeah.
Take it a little bit further forward. Okay, fine.
The guide is a little bit disengaged. Yeah.
Yeah.
Yeah. Okay.
Yeah, we need a fresh wire. This is
තව ආයක ගන්න බලන්න සියොන් blue ආයක.
I think damaged.
Yeah, not bad. Not bad.
It's okay. Let's take the microcatheter. So hang a
Just
second.
hang a
Let's
second.
take the microcatheter forward.
Guide keeps, not doing much.
Yeah, that makes me wonder whether that wire is behind the stent. See, the microcatheter is not going.
Yeah.
So, okay, let's rewire it.
So I'm getting the microcatheter back a little
Yeah,
bit.
back a bit. If you ibis this, you'll find that stent is swimming.
Correct.
It's too small. So we might have, but we need to get the wire here. This is not gonna go through it. Can I have a, do you have a run through wire or do you have,
Floppy run through
well,
or
a fresh cyan blue,
fresh
please?
cyan blue.
I think, yeah, this is.
Yeah, take it out. Yeah.
Okay, so again, one thing, can we take this wire out? Important to make sure that
Look at
you
these tips and tricks.
take the wire out.
That's important.
Because you don't want the air to be sucked in.
Yeah.
So this is the Venturi effect. The space has to be filled with something. If you pull the wire without putting saline, it's gonna suck air because the lumen is too small for the blood to fill it back. So you end up sucking air in. And sometimes in order to find your way through, you are gonna have to take an injection through this microcatheter.
Correct.
I can have the needle. So this is why you put the saline in. And so when you take an injection, there's no air in your. Let's see if you could. For now, just make a small bend.
Okay.
Just to be able to navigate through this.
But microcatheters, of course, if you're not bleeding back, you should not inject, and then also air embolism, you have to be very careful.
So the
for the viewers, it's a good
talk
tip.
around, please. Okay. Let's have a look. Let's bring the catheter back into focus so it doesn't commit me toward one direction here. Okay. Fine. Yes, just 1 second. Okay, let's go forward. Let's hope this will go through the stent rather than behind it. I could feel it hitting the. And I feel like if you take a hydrophilic wire, it will go behind the stent without any. So this will kind of almost maybe decide the strategy for us to go back to the, as if there's no collateral from the right.
See, this is the
So
original
what we could do is-
process, we had as well,
Yeah. That's Well, I mean, because these septal are safer than going through the epicardial. Yeah, this is behind the stent. You could feel it, you could see it. Often going through the stent is on a loop, much easier. However, in this case, I think there's a big space between the two. And yeah, this is not picking it up. Do we know what makes stent? Because no.
Yeah, this is Science 2.5.
Look, let's stop screening for a second.
Science
Take this
2.5.
wire. Take this wire away from me.
Not post-dilated.
Take it away.
Yeah. So again, taking the meticulous steps to make sure there's no Venturi effect.
Give me the other. Give me the older wire.
What do I?
No, the one we used at the beginning.
Yeah, with
You
the
just took out.
bigger loop.
Yeah, I'm just gonna see if you could lube it from at the beginning.
Yeah.
We might be able to go through.
Yeah.
Okay.
Hopefully. That should find
So we'll try to find a loop, form the loop a little earlier. Can you put the talker on for me, please? Just come to LAO for a minute.
LAO, please.
Shallow LAO, just about 20, 25 degrees at most. Where's the angle for this? Come to 25.
25. LAO
Thank
25.
you. That's more than
yeah,
enough.
yeah.
That's anything. Okay, that's good. Okay, unlock. Okay. Let's see if we could form a loop earlier on. Yeah, our guide is not very.
Yeah, that's not very enterprising, you know, the guide. But
See, still, even the loop's still hitting the stent and it's not going through.
yeah,
Is this behind it? I don't know. Let's advance this micro catheter and see.
get a little bit more support.
What we might have to do is take a guide liner actually and put that. That seems to, don't know. But it could still be behind, I think it's behind the stent again. It's behind the stent. You could see where.
Yes.
Let's take a cine, just a burst of cine. Look, it's underneath the
Yeah,
stent.
yeah. I agree.
Okay, it's too small, and let's just try again. I'm going to bring this back a
into
bit.
the catheter. Yeah.
Ah, you're still behind it. Because if it goes through the stent, you would expect it to fly, and it's not. Is this better? Don't know. No.
No, I think
still
that's
the,
still
the same
yeah.
area. Okay. Can I have a? Do you have a Miracle 3-wire?
Miracle wires, please.
That's not gonna do it. Okay, let's take this wire away. You could stop screaming. Take this one. Yes, please. See the little notions that you have to deal with. I mean, again, I could appreciate why this was not burst dilated, but I think it's undersized from the start. It's not a criticism.
Exactly.
This is what happens during acute MI.
Exactly.
The artery is small, and but the RCA in particular never it doesn't change the diameter that much.
Yeah.
Proximally, we could see that it's at least a 4.0 at least.
Correct.
So it doesn't. It's not going to go to 2.5 distally, but during the MI with the adrenaline, everything is a little spasm. Doesn't look good. So, but anyway, it's and the reason why it wasn't burst dilated, of course, because the no flow phenomenon is much more important. But this is now it's affecting what we do.
Exactly.
We'll try this for a couple more minutes. If it doesn't work, because all these complicated cases or difficult cases about being efficient or about being safe.
Yeah.
So if this doesn't work, we're just going to have.
You don't have Miracle? We have Gaia next.
Gaia is. It's not as easy to manipulate to go into these. What do you have? Like, do you have a Gladius? Gladius EX? So cases like this also now there's the Miracle Neo, Miracle 3 Neo. I don't know if you have it or not.
We don't have it.
Okay, the Miracle 3 Neo is a good. It's got a blunt tip and it's not as. Sorry. No, we don't need a Gladius. Gladius EX.
Do they have Gladius?
Do you have a Do you have a BT Choice Extra support?
We have Gladius.
Yeah, literally. Do you have a BT Choice Extra support or? And also the thing is with this stent, it hasn't had enough time to endothelialize.
Correct.
So the struts are gonna still be open.
Correct.
I'm trying to avoid the hydrophilic. So what kind of do you have a BT Graphics, BT Choice Extra support? This one second.
PT Choice, PT none.
Yeah.
PT Choice, yeah.
The extra sub, yeah, BT Choice. Let's have that and see. So yes, it hasn't had. So this.
PT Choice.
PT Choice.
We had some.
Fine, give me the Grand Slam. Give me the Grand Slam is a supportive wire. It's not, the tip has nothing to do with this, but it's non-hydrophilic. And let's see if we could manage with this. It's
stiff wire.
It's a stiff wire. It's got nothing to do. The tip is not any different from the cyan blue and the. But let's see if we could get it to work. There's no magic here. What's gonna work? It's just a matter of attempting to see if we could get through the stent. If not, I think we'll have to reverse to our original strategy. Otherwise, we will be wasting too much time. Set the talker on, please. Can you put the talker on for me?
Talker on.
Okay. this wire because it's a stiff wire.
Yeah.
Now even advancing it because we have the guide is not. So let's lift the guide up and turn it so
Yeah.
it goes into the artery, please. Lift it up and turn it clockwise. Yeah, okay, good. Thank you. And I'm going to bring this micro catheter back. See if this branch lamp will allow me to go underneath, not underneath the stent, inside it. No, it's still hitting. I could feel it. It's hitting the. Here it looks like probably inside the stent, probably. So let's just advance this. But I'm afraid.
I'm keeping the guide.
I'm afraid it could be just going through from underneath it, yeah, and then coming into it. But let's just see. That looks a little bit better. Stop screening for a second.
Yeah.
Okay, now we could screen again. Ah, my God. I'm not sure whether this is inside the stent or outside it. It's really, the wire is not going.
So
it makes
it's
me
difficult,
wonder.
you know, yeah. It's difficult
Makes
to say.
me wonder if it is inside. Let's just hold the micro catheter advance on its own.
I think it's going underneath the.
I think it's underneath.
Yeah, it's
I think
underneath,
it
yeah.
is.
I'll take an acquisition and
Yeah.
just to demonstrate. You
It's
know, I think
underneath.
It's underneath, yeah. So we'll
Okay,
have to
let's
come
bring
back.
it back a little bit and try again. It's, I think, yeah, we'll give it a couple more minutes, and if that doesn't work, we'll just have to reverse to our original strategy. It's a shame, but you know, it's you have to deal with what's in front of you.
Yeah.
I can't.
Yeah. So for
The
viewers-
only alternative is here just to try to see if we could wire it.
So for the
looks a
viewers
little bit
online,
better.
our original strategy initially was to see whether we can identify the entry point of the LAD by doing a IVUS through the left system through what we think is the intermediate. And then of course if we could clearly see it, you know, to use that as our IVUS guided puncture. But of course, given the circumstances, we decided to change that strategy. But anyway, we might revert, yeah.
This is underneath.
You're right, Prof. Yeah.
Okay.
So I think you know you're correct. Yeah.
Fine. Okay, we'll have to leave it then.
Yeah.
We could use now the retrograde just for visualization. I look at the collaterals, but then so go forward one. I will have to swap our change our strategy. Go forward one. Play it.
Play it.
Go forward. Forward. No, forward. Okay. Next. Next. I mean, there's an alternative that we could do if we take a soft hydrophilic wire, a cyan black, or make the knuckle a little early, or it might go through the stent, and which is probably worth trying one last time before
Can
we.
you have a cyan black, please?
Either that or a Fielder XT, one of the two. Let's take this wire. Take the wire away from me.
If it falls into a septal, you know, the cyan black might be helpful for you.
Well, yeah. I mean, if we're gonna go on a loop, it's. Yeah.
If you have a cyan black, you know,
It's
take a cyan black.
A shame that. Because you could see that RCA, it's at least a 4.0 before the bifurcation, then it's a 3.5. But
cyan black, please, yeah.
okay. We need to flush it first. When it comes with these, always needs to be flushed. So activate the hydrophilic. Okay, and all of it does a little bit.
Shape a needle. Thanks. මම මේක හදන්න පොඩ්ඩක් ඇවිල්ලා කවුරුන් ඉන්නේ මේ චිප්ටක් උඩට කරනවා.
Okay. Let's have the talk run again, please.
ඉස්සරහ හදන්න.
So then okay, talk run. Okay. Stop scrolling. This is
Get it.
closer
That's right, yeah.
away from us. Okay, here. Right, let's see if I could manipulate this inside the stent. Now it's hitting the. Oh, this is hydrophilic.
Yeah.
I don't. It's hydrophilic, so
you never know.
you never know.
Yeah.
Well, the micro catheter will tell us, but it looks like it's probably has.
Yeah, it's a different trajectory, right?
No, it's not. This is now. Look, it's pushing the guide out, right?
Yeah.
So I don't know. Let's take a burst of cine.
Yeah.
It looks okay. So we just need
Can
to
you mag
adjust.
it? Can you have this,
We just need to adjust the guide.
Yeah. Okay.
Just adjust the guide and lift it up and push it on. And okay, now let's come to RAO now.
Okay, so you can give a little tension on the wire for me, just to get the wire.
Yeah, no, it's, the micro catheter is not in the right
Yeah,
place.
yeah,
Sorry. Back to LAO. You could see that it's. Go back to LAO.
Hello.
Go back to LAO. Yeah. So the wire has gone behind the strut. Now let's advance this slowly. See if the micro catheter will go.
Okay. Sorry, I'll just
See, it's pushing the guide out, so it tells you that it's not in the true lumen, right? Now, if I get this, okay. No, it's not going. This is, if I spin it, will it go? Okay, it's gone.
It did.
Okay, come to RAO.
Yeah.
I hope it's not behind the strut.
Yeah.
But for now, we could deal with this after.
But at least we can wire it if we can get
Let's stop screen for a second. Go back. Go back for me.
Go back, please.
Back. And again. Well, no, if we wire it now and you try to come, you're going to have a lot of resistance going around the corner. So if we're behind the stent, we're going to have more resistance distally.
Correct. And then
But,
deform it,
let's see. And go back one again. Just play it. Back. This is LAO. You don't see. Okay. I want to see the. Okay, let's just screen for a second. And stop there. Okay, stop. Go forward. Yeah, play. No. Go back. Play this, please. That's a leash of these. But where the hell the septal? I have no idea. Let's see if we could. Okay, let's screen for a second here. I'm going to come back a little bit and see if I could access any of these. Okay, just 1 second. Stop screening for a second. Okay, let's. I think I need to advance this and change the shape of the wire. It's not. There's not enough bend on it. On the wire. Okay, fine.
Okay.
Let's stop screening. Take this wire away from me and keep the talker on. You take it away. Okay. So we're just going to make a bigger bend so we could access the septal.
So just whenever you possible, just show the viewers,
So yes, we're going to make a very small bend. I'm just trying to shape it if it becomes. So we're going to make a big bend in the back and a small bend at the tip. Yeah.
So bigger secondary bend and a smaller primary bend, is probably what Prof is suggesting.
Okay, let's have a little screen here. We could take a picture through that micro catheter, obviously, to show us me. Let's have a little test on the right. Inject. Let's have an. That has taken one. Okay. Inject. Okay, that's it. I'm gonna go to the one after it.
Yeah.
See if that will make any difference. I don't know. Test me there.
Test again,
Test
please.
please. It still doesn't look like it. Well, we need to change the wire anyway because the tip of the wire now is big bend. And as I said before, to access it, you have this big bend. But let's just
take the micro catheter.
Can we have a 3 millimeter lower lock syringe, please?
3 millimeter lower lock syringe, please.
So what we'll do, we'll just test me there, please. Test.
Test.
Just a little test. Okay. Okay. Let's take this away now. That's fine. Take this wire away.
Take the wire out.
So you cross the collaterals in one of 3 ways. If you see the connection and you know they are easy wiring, or if you're stuck like this, you take a picture and you could delineate it, or you could surf.
Yeah.
Surfing, when you don't see the connection, you're trying to take it.
Yeah.
This wire now we have a big bend.
Yeah.
We have a big bend on the wire, so it's not going to allow me to advance. So we might have to take a fresh cyan black, and just
fresh
make
cyan black, please.
and do a bigger, a small bend. When you're trying to cross the septal, you have to have a very small
Another
bend.
cyan black. No, fresh one.
Okay.
Ask
Let's
him
have a
to
little
bring it,
screen there. I don't think
No,
it connects.
no,
Let's
no.
take a cine.
Okay, ready?
Yeah. No, it
It's
doesn't
not
connect.
connected, yeah.
Okay,
Yeah, it's
fine.
not connected.
Okay. So it's no point.
So for the
now
viewers, you know,
I'm gonna bring
yeah.
this back, and of course now the most important thing. You could stop screening. The most important thing is just to flush the microcatheter. You use the contrast and you leave it there without flushing. In 5 minutes time, you know all the contrast, how your hand becomes
Correct,
sticking.
correct.
You have the wire in and it becomes stuck into the microcatheter.
Correct, yeah.
Important. Let's have the
All
cyan,
important points
the cyan,
again, yeah. What
the cyan black we just
cyan
took
black,
out.
fresh, cyan black, please.
No, the one we just took out, the one with the bend.
No, that's the old one.
No,
Bring the
just
fresh
the one. Not one. I'll take the one we just took out right now because now we've come out of the septal.
Yeah, okay.
We still need the big vent to access it.
Sure.
Again, I think with all what's happening in here, we need to be a bit more. Yeah, the one we just took out. Yeah, a bit more. Where's the needle? More efficient, and this is. These are the difficulties that are not very anticipated here, but I kind of thought it might be the case because I did think the stent is a bit small.
Yeah.
But
do you all be
it
fairness, you know, the operators
of course,
did point that out.
Of course. But undersizing is our Achilles. Let's have a talker on this wire, please. Okay.
So those of trainees, etc., who are watching, you know, what the Prof did was, you know, do the microcatheter, look at the microchannels, and there's no direct connection there. So when he injected with the contrast,
let's see if I could.
we're trying to find another path.
Yeah. And I did say that at the beginning. Often from the right to the LED is a very difficult connection. And you think you see a leash of everything is gonna just fly, and it doesn't.
It doesn't. Yeah.
It just does not. Go to BA cranial for me.
BA cranial, please.
And again, so efficiency and safety. We'll try this for a few minutes. If it doesn't work, then we'll switch to a different strategy. Otherwise, let's have a little test on the right, please.
Test, please.
Test.
Test injection.
Yeah. Okay. Go on.
Yes.
If anybody could. I know. I said
Tempting.
there's screen. There's a leash of them. It's just kind of, this is going to be a matter of luck whether we pick one of these or not. It's not going where I want it to go. Little test there again.
Test there, please.
Test. Yeah, this is not going where I want it to go. Yeah,
That
okay,
one.
fine.
The one on the
Too distal, and I don't think it's. I want to go to one of the proximal ones. We might have to have a bigger bend here.
check.
Test again.
Test again, please.
Now it's a VE, so it's not running in the right place, but yeah, it's not. Okay, stop there for a second. Okay. Just go forward.
Forward.
Next. Again, you can see lots of collaterals. Where are they coming from? If anybody could tell me, and this is typical of the right coronary artery, particularly with tortuous distally. Often it's kind of a matter of luck occasionally. And it sometimes could be coming from a small branch of the PDA. In this case, let's go to this view here, areocranial, and we'll try it quickly. If this doesn't work, we'll switch the path. So go to areocranial.
First tortuosity there appears to be the connection.
Areocranial.
The same way,
Well,
please.
let's try.
Yeah.
Let's try and see. Because we're
RO 25, cranial 31, please.
yeah. Okay.
Yeah.
So let's have a little test
Test,
here.
please.
Test me, please.
Yes, that leash of vessels, yeah.
Okay.
Okay. Check.
It's not behaving as a proper septal that connects. Stand this. No, it's not. Okay. If I advance this microcatheter, it might give me a better. This is going somewhere not right. You see the VE, so when you're surfing, you're going moving your wire quick. Little test there.
Test there, please.
Yeah, it's not right. See lots of VEs
Yeah,
here and the wire buckling. So the last thing you want is to push, because if you form a knuckle, the septal usually splits.
Yeah.
And that's when it makes it. The perforation is not, they don't perforate very easily, but they split longitudinally.
Yeah.
And I think, okay. All what you need to do, see if we could.
That
Don't know,
kind of-
don't
yeah.
know. Don't know. Test there.
Test there, please.
Test me there. Having lots of ectopic, so I think it's not in the right place at all. Yeah, it's not. You could see they're going down. Okay, fine. Okay, let's just leave this alone.
Okay.
I think we've tried. We've given it enough time.
Okay.
So what we might have to do, leave the wire in place so you could dilate the stent.
Sure.
We could leave this wire in place and
Yeah.
we could leave the...
So we take the microcatheter out.
Yes,
and leave
we'll
the
take
wire
the
in there.
microcatheter and we'll leave the wire in there.
Okay.
We just push the wire at the end. Okay. Okay. Just come to BA for a second. Let's have the indiflator, please. Carry it. Just give me a little squirt, just gentle squirt.
I think we selected
No,
a
no,
good
just
case
a
for,
gentle-
first
gentle.
up front.
Little squirt, just very gentle turning. Very gentle. No, no. Keep it this way and just turn it
Yeah,
close so
turn
get
it,
rid of the air. Just gently. Okay, stop now. Stop.
So this is to flush off. You can see
So-
what Prof is doing.
I want you to go to 16 and keep it at 16 without moving from your place. So go to 16.
Yeah, this is another trick that
Keep
people
it
might
at
want to
16 and
see.
don't move it. Keep it at 16. Go, go, go. Keep it at 16.
16.
Keep it at 16. Keep it at 16.
Nice.
Okay, that's
Okay,
fine.
nicely done. So that's
Clean
another.
that for a second. The wire
Yeah, you're fine, yeah.
remains good.
Yeah,
So the
excellent.
wire didn't move.
Yeah.
The key about this is for the assistant not to move
Yeah,
and to maintain the pressure. It's the hydraulic pressure that will flush this out.
correct.
If you're concerned, you always trap because you don't want to lose. In
Exactly.
here, so I think we could deal with this later,
Yeah.
right? Because it's not just to make sure. Because I'm seeing a lot of VEs. Is the wire in one of these branches? No, it's okay.
No,
We'll
it's
just
okay.
leave it there.
Yeah.
Fine. Okay.
Okay.
Now let's go forward. We'll have to change strategy. We could take the IVUS
IVUS.
and see what's happening.
Yeah.
Let's have the IVUS catheter, please.
Oh, that's okay.
How long? Yeah, flush it.
Yeah,
Because there's a
keep
contrast in it,
Yeah, yeah.
so we don't. How long since the ACT, guys? So it's important also when you're doing CTOs to make sure that you maintain your vigilance about the heparin. You check it every 30 minutes,
What time
so you
is the
don't.
heparin given?
So
Time? Exact time? 9:10.
and the ACT was done when?
ACT?
When it was
9:15.
an hour ago. Okay. So we need to repeat another one just
another,
because. And often the ACT is important for the retrograde. You don't want any thrombosis during the. Again, hopefully this IVUS will show us where
Origin of the.
origin of the LED is, and if not, then the last thing we're gonna go for the epicardial. Epicardial, I'm a little because we don't have the proper wires, but we should hopefully be able to access it. So we'll see. Okay,
That's for the ACT.
let's take the ACT.
So document the time 10:05, 5 minutes past 10. Okay. We'll do that.
You have to insert it here a second. And pull the white bits, please. Yeah, pull it all the way. Go. Silence this.
Reduce the beating.
There's some
pace.
clean saline in these. Yes, both of them.
This needs to be stuck in here, no?
And yeah,
Yeah,
once
yeah,
we put it in,
Yeah.
we'll get it sorted out. Again, when you're using IVUS to identify the proximal tab, it is not the most, it's not always as, because I always call it the 50 shade of gray.
Yeah.
So there's calcium, there's fibrosis, and it might not be as easy as you think it should be, but hopefully in this case we might be able, given his age, we're not going to have too much calcium or too much ambiguity, but you never know. And what we could do next one is put a wire in the circumflex to allow me to kind of identify both of them, and then we'll see. How do you reset this? Here we go.
So for the viewers who are not familiar with it, this is the IVUS catheter. It has got the optical element down here. Okay, so we're going to introduce it on the left system, short monorail.
Just come to BA caudal, please.
PA caudal, please. Hold the wire.
That wire might need to be pushed down a little bit, but we'll do
Yeah,
that.
that's it.
Okay. Let's get the
Because the
IVUS
length
in.
is not
Okay.
enough. Yeah, correct.
And we'll take, we have a second cyan blue, right? There's a second cyan blue somewhere.
Hurry. Yeah, okay, but the ACT, we are waiting for the ACT report, okay?
Yeah, bring the IVUS up. Bring the IVUS up
Closer.
here.
Closer, please. Okay. So,
Yeah, we still have, you don't need to screen.
Yeah.
You still have the marker.
yeah, marker
on
there.
it.
Yeah, that's right.
So we're going to introduce this. And this is where the 8 French becomes relevant, because we're going to put the wire into the circ to allow us.
Okay,
Got
so,
it? Okay,
yeah.
so, okay, let's have a little test here. Let's go live on this and find out.
Okay.
There's a lot of calcium there, so that might make life a little bit more difficult than we
You can
think.
see the IVUS screen there. Okay, so,
Okay, so we need to come back. Let's bring it back. Let's have, first of all, before we do this, let's have, what's this wire and where's the cyan, other cyan blue?
also cyan blue wire.
We'll stick it into the
Second cyan
circumflex.
blue wire, please.
Yeah. So, where's the needle?
Needle, introduce a needle.
Okay, so let's put this in the circ.
Yeah. Light का adjust करें.
Yeah, it's okay. Just, if you do it with your finger, it'll be okay. One second.
Yeah, other side, back.
Hold on to this. Hold on to this. Yeah.
Backload.
That's not going to
Backload,
this might make your life
Yeah,
more
yeah,
difficult
yeah,
getting
yeah.
to
You
the
don't
circ,
want to-
but anyway.
yeah.
So I think what we'll need to, once we've done this, what we'll need to do is we'll take the micro catheter again,
Yeah.
and I think we'll take a Corsair 135. Yeah. Maybe a Corsair 135. Well, actually, no, make it a Caravelle. Because it's
Caravelle.
seven French, we're not
Caravelle,
going to be able to.
Yeah.
We're not going to be able to accommodate all. So Caravelle 1. Don't open it yet. Just hang on a second.
Have it ready, but don't open yet. Okay.
So as you can see now, we've gone down to the which is fine.
Yeah.
And what we'll try to do. Okay. Let's get you into the. No, it's okay. We'll take the Caravelle, but just hang on. Don't open anything yet. Okay. Yeah, that's the problem with this. Okay, if it's okay, good. Good, fantastic. That's enough. Okay.
That should be enough.
So now we need to bring the IVUS back.
So shall we do a run and then
No, just we'll bring it back manually
Okay.
until we see what the bifurcation is.
Okay. So we are doing a manual pullback on the
Yeah.
IVUS.
And we need to
We can
flush.
flush, please. Flush.
Where is the?
Flush the name.
There you
Yeah.
go. Okay. So let's bring it back
Okay.
until we see the circ wire. So we're still in the proximal part. This is a huge artery. It's
Yeah.
at least here we go. Slowly. We missed it now. Just advance it slowly a little bit forward. So here's the circ wire coming from up.
Yeah.
So bring it back slowly again, very slowly. Back. Oops. Back. Okay.
That's the circ wire. Yeah.
Yeah. Where the hell is the LED?
Exactly.
That's why I said 50 Shades of Grey, very difficult. So
yeah.
I think this will tell you that we are going to have to. Just can play with that for a second, please.
So I just wondered whether we should do a run, total run, and then try to identify.
You know, but
what
I
the
mean,
mark
it's total run is going to go quick, and we're not going to see what we need to see. To be honest, we can, but
is.
So here we are, the two wires. That's the circ wire.
Yeah.
The LED is somewhere there, but with the calcium shadowing everything, with the lots of black disease, because now the circ is on the top.
Yeah.
Yeah, you can't tell. And the other question becomes, is the LED really there? So I think if that's the case, let's just go for the retrograde from the epicardial. End of story.
Okay.
It is going to be a bit difficult because we don't have the Sohe 3 or anything, but we'll have to try it. What's the pressure now? 89.
Yeah, we can turn some fluids, please.
Okay, fine.
Pressure. Yeah.
Right. So let's take, I think this is the circ wire, right?
That's a circ
We
wire.
don't need it. Take this away from me. Make life a little easier. We could make a run now that you're here, just record it because we're not. And often the way you identify this if in your branch is a small diameter, and you're coming back when it changes the that's okay. I've done it. When it changes diameter, you know that's where the in this case, it's okay. It's pulling back. It says 0.5. So there's a lot of disease in there. Can you change the speed? I mean, too late now, but it's okay for now. Let's just keep going. We'll probably migrated too much in, but that's okay. So that intermediate is at least a 3.5.
Yeah.
Really big, lots of disease. That's what you see on echo and ultrasound.
Yeah.
So we leave that. It's not. We're coming close to the proximal part. Don't need to
That's the
screen.
circ.
Yeah, that's the circ. And now there's calcium in there. So I think we could, from what we've seen in the diagnostic, we could be a little safer. Try when I thought the LED is, we could stop this now. Okay. Fine. Okay, let's take this out.
Yeah. So IVUS comes back.
Yeah. Okay. Let's move the IVUS back.
IVUS away, please. Yeah.
Make it away. Take the IVUS away. But we don't need it. Okay.
So what would you suggest? Should be
so we're gonna go for LAO code. We'll take that little picture. We'll take the Caravelle or the Corsair 135, and we'll try to where we thought it's the area to puncture. You don't need to screen. You don't need to screen.
No, you don't move the wire.
Right. Okay. Why is the pressure down? The pressure has changed. It's less. I mean.
Can you get some fluids for him?
Yeah, just get some fluid. His LV is okay, so let's give him some fluids. I just wonder whether our catheter is sitting on the aortic valve. Let's lift the left catheter up a little bit. Just maybe sitting on the aortic valve. Okay, fine. That's good. Let's see if that changes the pressure. Let's give some fluid, and we need to go a little bit more LAO. And so just the suspicion from last time is like, 1 second. Okay. Yeah, this doesn't help me. Okay, a little bit more LAO. Stop screening for a second. Stop screening until they get go. A little bit more LAO. No, LAO, not caudal. Less caudal. Okay, go LAO. Okay, fine. Good. Okay. Screen there for a second. Oops. I need to do. Yeah. Let's take a cine.
Okay, right?
Yeah. Okay, fine. Good. Right, let's have that Corsair 135.
Corsair 135. Corsair
Caravelle,
right?
Well, no, Corsair. Okay. Corsair 135, because we're going to go integrate.
Sure.
So I'm just going to poke in that area.
Sure.
And we'll try it with a kind of a baby Gladius EX and see if that will work. If not, we'll just go straight to retrograde.
Yeah.
Okay. Yes, flush it from the outside first. Okay, that's good. Thank you. Now we'll flush it from the inside.
Okay.
Right. Can I have a Gladius EX wire?
Gladius.
Of course, we could take a Gaia, but because we're not sure, the Gaia will cut through the tissue and exit without any. You don't even feel it. So I think it's not the right thing to do.
Yeah.
The Gladius is much more. Yes, it's got the penetration power about 3 grams, but it's unlikely to exit, unlikely to cause. Not MG, EX.
Yeah, just play that one again. So just play that again.
Play the last
Yeah.
screening.
There's a little double marker down there, whether it's calcium or whether there's a little bit of a track.
So I'm thinking
Parallel
there's
line.
on top of
Yeah.
that intermediate,
Yeah.
the LED is there. I don't
But,
know.
yeah, exactly.
It is kind of not a risky strategy, but
Yeah.
I think it's anatomy doesn't lie. So where's the LED gonna come from? We don't see any appearance from anywhere else. So let's have that Corsair, please, 135. Oh, here it is. Okay. Yeah, here it is. Okay. We flushed it. So, okay, hold on to the wire and hold on to the wire. Okay, let's introduce this Corsair into the retrograde, into the antigrade. No, not nice. Next to it, next to that,
Okay.
next to that.
So,
Because we're not going retrograde yet.
okay.
Okay, let's close the O-ring, push the wire up, please. Push the wire up, push the wire up. You don't need to screen. You don't need to screen. Too early. Push the wire up. Okay, push everything up. Push it up. You don't need to screen. Push it up. Push up. Push up. Push up. Push up. Okay, now you could start screening. Okay, I'll let the wire come. Yes, screen. Okay, keep going. Okay, I'll stop here. Stop screening and push the microcatheter. Don't screen.
Okay.
Yeah, take the microcatheter in. Keep going. Keep going. This is 135. That's 100 centimeters. Now you could start screening because you're starting to come close. That's a little thing will save you. Okay, fine. That's enough. Let's have the talker on. And of course, no, please leave it. You pulled it back now. It's okay. Let's have a look and see screen. We might have to put a bigger bend on this wire. Let's have a small bend, but let's see. Stop screening for a second. Okay, now you could screen. Can you give me a little test on this wire?
Please. Little test.
Yeah, we need a bigger bend on this wire.
Okay.
Because that's gonna keep going into the. Okay, fine. Stop that. Take this wire. Keep the talker on. Move that wire away. Yeah. Needle.
Introduce a needle, please.
Just put the bigger bend so we could reach that area.
Okay.
You don't need to screen yet. Because we left the talker in place, so that tells me when I'm close, I know when I need to screen because we're still, again, this is about, okay, let's screen now. Here we go, very close to where we need to be. Let's see if I could,
A little track.
little test there.
Test, please.
Test, please. Test. Okay. Okay. Okay, 1 second. Okay. Stop screening for a second. Right. That's me there. Yeah. So, how sure are we is that's the LED? Because if there's enough confidence, we can take a more penetrating wire. This is hydrophilic, so stop screening. What's going to happen with the wire, it'll do, the wire will choose the least resistant path. So if there's a proximal cap that's severely calcified or fibrotic because of occlusion, it's going to keep deflecting to the branch, and that's what's happened. So you need a wire that is going to hook into the lesion. You could drill it. A Gaia X3 or a Confianza or something, but I won't be using this until I'm absolutely sure this is where I need to go.
Correct.
It could be just these wire will penetrate through. So, but let's try this for a little bit longer, see if we could get any access into it. No, that's going through that, which is what you'd expect. Okay, I think. Okay, stop screening. Questions, and can I? Let's screen this. Okay, fine, let's leave that for a second. Let's take that matter. Okay, take this away for a second. Leave it. Let's have the final cross. We'll go to epicardium.
Okay. Fine, cost 150, please.
There's 150. This is flushed and clean, yes?
Yeah.
Right.
So we are changing the strategy, hoping to go through the diagonal.
The only reason why is because I'm not 100% sure that if I take a stiff wire, I'm poking in the right place.
Yeah.
I didn't see anything on the IVUS.
Flush.
You flush it again, please. Never hurts to flush. Okay, good, thank you. So, okay, keep it straight. Okay, it's okay. It's okay.
Curled a little bit.
It'll stop. Just 1 second, 1 second. Let me just take it.
You do it.
Screen. Okay, hold the wire. Okay, good, thank you. How do you close this?
Just push it up.
Fine. Now, go forward. No, you don't need to screen.
Okay.
Go forward for me. Go forward.
Forward with the.
Next. 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 Just go back one. Okay, identify the. Next. Next. Okay, let's go to this view. Arachocranial.
RO12 cranial 35, please.
So again, you could see the contractility in this wire. Controlling the wire now is going to be quite difficult. And these are not the specific wire for this. So the SOA 3 it's a coreless. It's almost like a spaghetti. So it will follow without causing much issue. But what we're going to try to do, sorry, come go forward, play that. And I'll tell you when to stop. No, keep it playing, I'll tell you when to stop. Stop. Okay, just roadmap that. We could see there's a epicardial collateral just coming through. You could roadmap it there. See, that would be hopefully, but because of the contractility, controlling the wire could be a bit difficult. Let's have the talker, please. Talker,
please.
Okay. Now, let's screen here. You could see, unlock the table.
Unlock the table, please.
Okay, lock it there. Okay, stop screening. Right. So I think this wire might be damaged. We might have to take that and the other wire, but that's okay. Let's have a little test.
Test, please.
Test there. Unlock once again. Unlock. Okay. Test there. Test.
Test, please.
We need
better guide.
Let's put the guide in. So you could see, test there. You could see the movement of the tip, and that tells you how difficult it is to control it. But nonetheless, we're gonna try to.
No, it's not.
It's not in.
Let's check that. Yeah.
Okay, that's better. Okay, fine.
Ready for
so we don't need to see it. We're just gonna. Okay, test again.
Test again, please.
We're close, but no cigar. Let's get this. So hopefully the micro catheter will help me overcome this tortuosity. Little test again. Yeah. So, right. Let's have the cyan black. Take this
Cyan
away.
black, please.
Take this one away, please. So do you get the concept of with the contractility, it's doing this. So the control of the wire is very difficult, particularly these wires with the core, sometimes core to tip. So that's why. You sure this is cyan black? This feels like the gladius. That's the gladius. That's the gladius. We just took it out and still have the talker on. So again, you take a gladius and here we'll be in trouble. No.
That's very stiff.
Let me have a look. Where is it?
Cyan black should be very soft.
That's the cyan. That's the cyan blue, isn't it? Where's the other one?
On the table.
That's the other cyan blue. So we only took one cyan black, right? Not two. Incidentally, the average, no cyan blue, this is a cyan blue. Right, let me see if this will work. I need a bigger. The mean number of wires for CTO, particularly for retrograde, about eight wires. So, and as we said at the beginning, you have, I mean, each wire has got a task, it's got a property and a task. And this is all about knowing your equipment and knowing which equipment is being used for what. So, okay, let's have the talker on. I think we will need a cyan black, a fresh one anyway, because this one is down there. Okay. Okay, let's have a look here. See, that's why you understand why controlling the wire in this way. Let's test there, please.
Test there, please.
Test there. We need the one on top of it, yeah. But of course, I have not much control of this wire. What I'm going to try to do is this micro catheter to get rid of that tortuosity. But of course, let's see how it jumps. Because the contractility on this wire is not the right wire. Can you give me a fielder XTR, please?
Field XTR.
Test again.
Test again, please.
No. 180.
180.
Yeah,
It's making a 90-degree bend and then coming.
I know, so and with the contractility, I've got no control. Okay, let's stop there. Okay, take this wire away. So the next closest thing to the saw is the XTR, but it's plastic jacketed tapered, so the control of it is not as the. So, but let's see if it will work. It's okay. Just leave it, please. Just feed it back, because I'm shaping it. It becomes a 3-dimensional. It becomes difficult to control. Just leave it there for a second. Yeah, thank you. Just leave it. Okay. You feed it back in, back in. Okay, you just put it in there, rest it there. Thank you. Okay, let's have the talk on, please.
Remind us in about another 10 minutes in about the ACT again, okay?
Okay, let's have a little screen now. Okay. Little test again, please. Test, please. Okay, let's stop here. Come to BA cranial.
PA cranial, please. PA.
More cranial. Unlock the table for me.
Unlock.
Yeah, I don't see the bifurcation.
Yeah. It's further down, right? Yeah.
I know, but I don't see what the bifurcation. There was a view that we were able to see it. Just go a little bit LAO, just crane a little test there. Nah, again, it doesn't help me here. Okay, stop screen. Come a little bit more areocranial. Let's do it. Probably, yeah. Yes, I don't know where it is, but let's try.
Yeah.
See if I could get it in. I know it's just kind of. It's not. Yeah. Yeah, these are not the correct wires, if I'm honest. It's right. The other, do you have a scion wire? Normal scion wire. Test me there,
Scion
please.
wire, please.
Test there.
Test, please.
Test, please.
through that bend.
And of course, if I try to push the microcatheter on top of it, with that contractility and the soft bit of the wire, the microcatheter will just jump and could perforate. So I want to get this a little bit further forward. So okay, let's do it with the scion. Take this away, please. Leave it on the side. We're going to use it in a minute.
Please, yeah.
Give me a scion wire.
Yeah.
And again, we're changing these wires just because, as I said, the Soy 3 will jump through these without any issue because it's got no core. Oops. Okay, hold it there. It's got no core, so it might. It doesn't get too much affected with this contractility here. And often the epicardial and the lateral part of the heart are very difficult to overcome. Very, like we could see in this case, because the contractility always limits. What we might do, actually, hold on to this for a second. Where's that 3 ml lower lock syringe?
3 ml lower syringe. 3 ml.
Yeah, give me that. I'm gonna try to take a picture through this and see if we could see the anatomy a little bit better.
Yeah.
I know it connects, but where it's coming from and with all this tortuosity, it's very difficult to. Let's take a cine.
Okay.
Okay.
Yeah.
Can anybody tell me? It's somewhere there. I know.
Very good down.
Let's take a cine again. So sometimes the contrast. Okay. Fine. Let's have that scion. Again, I use a pure contrast, and when you do the saline, you get a better picture sometimes because it's more dilated. But that tortuosity is going to make life very difficult. Let's have the talker on this wire, please. Talker on. Yeah. Next one, screen. And don't forget also, this is a fine cross. So again, it's not the same, doesn't handle the same as the caravel. Caravel would be much better. If the scion wire will take me down to where I want to go. Test me there, please, again.
Test again, please, again.
It's not even advancing.
That's the bend that's making your life difficult there.
Of course, because everything is great, but we'll see if we could advance it a little bit more. So of course now, that's better.
That's better.
Right. At least see how it's straightened. That's I'm going to take the microcatheter. Just stop there for a second. Stop. Go back one. Go back one. Back again. Right. Okay. So I will probably bypass that. Let's screen now. The wire has come back. Again, I didn't touch it, but the contractility makes it. Yeah. Test me there. Test, please. Okay. So we're very close to where we need to be. See if this will go, because again.
That's encouraging.
Fine.
Yeah. Okay.
Test again. Oh, see, it's jumped forward without me doing anything here. Trying. See that little bend? That's where it needs to go. No. Nah. Yeah, these are. I said it's not the right wire, but I'm trying to see if I could do it. Test me there again, please. Take the XTR now. Come on, just be a nice.
It's trying to visit it.
It's trying, but it's okay. Let's try take this one away. I'll take the Fielder XTR. Take this one away. Again, you know, we're trying our best. This is not the right wire for the right anatomy, but the Fielder XTR we just took out. The last one we took out. I thought we were gonna leave it here so we don't get mixed up. This is the one we just took out, yes?
Yeah, sir.
Okay. Let me see. No. Okay. Talk around. Can I have a little test again, please? Oh, the microcatheter has come back. And again, I didn't do anything, just the contractility brings it back. So now, so this wire is not going to do the trick. I have to use, okay.
Take the other wire back. Yeah.
Take this one away. Leave it here on the side so you don't get mixed up, please. And can I have the scion we just took?
With the one that we took out just now, the Sion.
Pass me that, please. That sometimes actually happens if you don't pay attention. So when you take your wire of the microcatheter, because of the contractility that keeps coming back, and this will happen in here, but that's okay. Let's talk around.
Talk around, please. Talk around a bit.
Okay, just put it in this one here. Okay, let's have a... I'm gonna try to go all the way down if I can.
I probably put the microcatheter all the way down there.
I did, but it came back.
Came back, yeah.
Okay. It's that little bend. You can see how it's doing. We're gonna try. I jumped. I didn't do anything. So this looks like it's gone. Little test there, please. Test,
please.
Test, please.
Yeah, it seemed to have taken the...
I hope so.
Yeah.
No, it hasn't. That's not the one. Okay, wishful thinking. Again, little movement and the thing just jumped. Yeah, I think this is, with these wires, is hopeless, if I'm honest. I can't see this is doing it. Little test again, show me where I am. Test. Okay. Again, if you haven't done, let's take this wire. I'm gonna keep this microcatheter down. Take this wire away. Take this wire away, please. And I'll have that Siam, the fielder. The one we just here. That's why I said leave it here, please. You just leave it. When we say leave it there. Okay. Let's make sure that's not coming back. Okay. It's okay. Just leave it there because it's easier. I know that we're gonna use it again. Let's see if we could access this little buddy. I wouldn't be advising to do epicardial unless you have done many septals and many retrograde, because these could rupture and could really cause a big problem without any. Keep the wire on, keep the talk on. You have to handle them with respect. You have to treat them very, very gently, because if they rupture, and they could easily rupture, and you saw how the microcatheter jumps. Okay, little test again, please. Let's see if this will take us where we want to go. Okay. No, it's not gonna do it. Oh, look at the wire, right? I'm not doing anything, and this is just the contractile power of the myocardium. Little test there. That's okay. Test. Come on. Test. Good. Test. Is it in the area where we need to be? Let's get the guide on top of this. Before this, push the guide on for me and test. Don't know actually. Just stop there. Stop there for a second. Just stop screen. Go back one. It might be where we need to be. Go back one. Okay, and screen now, please. Screen. It's probably where we need to be, but I'm not sure, if I'm honest.
Why don't you get the micro in?
I know, but if it is
and then inject and then control.
the wrong place, we could be in trouble here. No, It's okay. Yes, this is now where this microcatheter becomes a problem rather than a hindrance, rather than a help, because
you need to take that bend, right?
Yeah, and that bend is not in a loop. I need to see the guide again. It's because the guide is moving out. Okay. No, it's okay. This is where the caravel might be, because you could spin it. This one is not. You can't spin it, but I'm gonna try to.
Guide is out.
So I know it's all out. It's all out. Okay. Right. And again, this is just the contractility. It's gripped. Right. Take this one away again. Take the wire away.
So let's try to rewire.
One more time. So again, if it is, sorry,
Previous
this
wire,
is the
please.
cyan blue.
Yeah.
We'll leave this
So
for a
leave that
second.
wire on the table. Udeni, leave the wire on that table.
Take the cyan, the normal cyan, the one we just took
Yeah.
before.
Cyan wire, please. Again,
Come
back
to
this.
BA Kodo.
Second, yeah.
Is that the one we just took out? Yes, the cyan, yes. Okay, talk around. I just wonder whether we should put a guide liner in. Yeah, well, yeah, just to get into the artery because we're losing. Yeah, let's put the guide
That is
liner.
the case then, yeah.
Yeah,
Guide liner.
7 French guide liner, please.
I think we have
Or telescope.
6. Yeah, yeah.
Oh, 6. We don't have. You don't have 7.
Magila kita kaki be telescope aku ya meke me medtronic ke kaki magi me
Just move that away. Move it. Yeah.
Argan magi meke.
I mean, if you don't have 7,
No, I
that's
think
okay.
we
But
should
if
have.
not, okay.
Bag card largan.
You know, if I'm honest, I wasn't thinking we should not try this, but I'm trying to give him the benefit of the doubt. If you don't have, yeah, we keep it there. Keep it there for a second. You saw that it's the knuckle, and I did knuckle through epicardial. These kind of, because it's soft wire, but because on the knuckle the micro catheter wouldn't go, and it is with the contractility, we straighten it out, becomes even more friction and more resistant. The caravel, you could spin it a little bit. You're not supposed to, but you can in these cases to allow you to go through these epicardial. Now, whether we could go back to the same one or not, I don't know.
Yeah.
We're going to have to try. Ideally, you don't want the knuckle.
Medtronic telescope Medtronic के तीनों telescope के लगा तीनों मगे लगा मैं guide extension
7 French.
7 French करेंगे मैं गलत तीन में yeah, just keep it connected there.
How long since the ACT, guys?
Yeah, I think it's time for another one, right? I told you 10 minutes to half an hour, 35 minutes ago since that. Yeah, shall we take one? Yeah. Take another ACT, please. Oh, you got it. Okay.
You find it?
Just show it to.
Yeah, 7th, that's fine.
yeah.
Telescope, that's okay. Good. It doesn't flush. We'll wet it with some saline in a second. Okay.
Pressure के दान मैं लाइन के pressure के दान मैं उड़े देना.
Yeah, it's bleeding back.
Yeah, pressure का अक्सर आना. Pressure के दान में.
Give me that fine across, please. The micro catheter. Yeah.
Tahu jahan ne. Tahu pressure क्या मिला मैं.
Come on.
Let me place together.
That's why we take the 7 French, because the 6 French, try to introduce anything, it becomes quite... Ideally, we should put the wire down, but that's okay. I'll do it this way.
Yeah.
Okay.
One.
Let the wire come. Let the wire come. Don't touch it. Thank you. Have to test there, please.
Test,
Test.
please. Test.
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 We'll Marty, test there.
Test, please.
Okay,
Yeah,
good.
yeah, fine.
I'm going to take this micro guideliner now down.
The guideliner 7 French is going to be going over the microcatheter.
Hopefully, give us look at that on the ostium of the LED. The
There
left
is a
main.
little bit of calcium in that, you know.
I think there's some disease, so hopefully that's not going to cause any issue with the pressure. But okay, that's fine. Stop screening for a second. Just go back to that cranial view we had. Go back
a bit of a
one.
damp and pressure trace, but it's okay.
Yeah, it is. Well, the left main is
Yeah,
diseased.
exactly. Yeah.
So
Yeah,
we're going to have to. Okay, we'll give him this quickly, and then we'll take that out because I think he might become ischemic, and we don't want that to happen.
Yeah.
We don't
Question
want.
one, the ACT key ACT key. Repeat it. Yeah. So when the ACT is ready, tell.
Posture left main is significant, isn't it?
Yeah.
Go back. Go back with the images. Yeah, play that. No, that's the coda. Yeah, this one here. Go to the same view, please. You're at the same view, yeah? Are you
the
back
same
at
view.
the same
Go back.
view?
Go
No,
back.
not this one.
No, previous one. Yeah, there, that
This one, yeah.
Yeah.
So
RO 20, 30, 37 cranial.
Okay.
Okay.
Test me there again, please.
Test again, please.
Make sure that. Okay, good. Yeah, this is a very tough case in the way that the anatomy is very ambiguous.
Yeah.
And now, of course, we wanted to do the guideliner, but the ostial left main is diseased. So,
Yeah, you can see the challenges. You know, that's why we handpicked.
but
this
there's a
case
lot of things you could do, and slowly, you know, you
Yeah,
get
yeah.
to. Again, gentle test there for me, please. Test.
Test, please.
So the microcatheter will jump through. Okay, fine. That's good. Okay, let's take this one. I'll take that. Take that away. Stop screening. Stop screening. Let's have the fielder XTR.
What is
Yeah, is this the one? Yeah. Okay. Now it is on a loop, so whether it's gonna work or not, I don't know. Might have been buggered this one. Okay, let me see. Well, we might have to. Let me see if I could go on a loop again, and whether the loop will follow the same course or not. Sometimes, because as I said, the contractility is what's controlling everything for me. It's not. It's
Do you
not me.
want the introduction unit? Through that.
Yeah. I think we're probably gonna need a fresh one. Yeah, can you fetch me a fresh? Stop staring at the wire, please.
Fresh.
Feel the XTR. XTR.
Same one.
Yeah. Can you feed this from the back? If you feel that XTR.
Here, the ACT. 338. Okay. All right.
Okay, good. You need to keep it above 300
Yeah.
when you're doing retrograde
30
all the
minutes, you
time.
know, so
Yeah, I think this is not going to work, but we'll see.
worth you to try.
I'm conscious here the cost is
Yeah.
prohibitive, but
Yeah.
these cases, I mean, they are costly, but you know, it's. Let's have the talk around, please. Just to go straight. If you try, you don't need to open it too much. The more you open it, the more difficult it becomes. Once it goes straight, it doesn't. Okay, let's have a little test there. Okay, let's just get this in. You don't open it yet. Hang on a second. If we could do this without... And can you test me there? Unlock the table. Unlock. Okay, test there. Okay, so we're not even close, but let's see if I put them...
With the loop you managed to...
Yeah, so it's going straight, this loop. So this time it's not going to work. So we might have to have a fresh one, but let me just do that again slowly. So we have to change it again. Test me again, please. It's just trying, but it's...
That is encouraging.
Right. It's come back too much now with the little... my God, okay. I think this is not going to do the trick here. And I don't want to damage this. Test me then, test.
Test again, please. Again.
Okay. Let's advance this a little bit further. Let's move too much. Test there. Let's test.
Test there again.
Let's cross the area, isn't it? No, just about.
No, I think yeah, okay.
Test
there again.
Oh, come on. No, that's not. Okay, let's have that fresh
Fresh field XTR, please.
one.
Yeah. XTR, upper. Fresh one.
Needle. I suspect this microcatheter has migrated down because there's no blood coming back, just against the wall in the distal part. Okay, let's put the talker on, please. That's okay, we'll handle this when we come back and see what happens. Okay, screen there for me. Okay.
Get ready to test.
Test me again, please. Test.
Telescope.
It's okay. Just want to get this down a bit. I'm not sure it's in the right place. This is going wrong.
The wrong direction.
Let me just see what happens here. See where we are. Yes, I don't think it's the right place. Test there.
Test there again, please.
No, it's even early, much earlier than we need to be. No, it's not better. It's gone. Give me that for a second. Let's take a cine.
Yeah.
No, okay, fine. We are in the right one, but it's turning up too early.
Yeah.
So screen that for me. Again, I've got no control of this wire. It's just doing what it wants to do.
But yeah.
Just one second.
Yeah. Okay, that's great.
Store that.
Store that, please. Okay, so you could see that it once it found the right channel, it kind of.
It's fly, but again, it's not screen for me. Screen. I just want to follow this because now this is. We need to bring that guideliner back because he's got. Again, this is where the fine across is not the best, but it'll do the trick. Fine.
Okay.
Let's have the Andrew. Okay. Take this away, please. Okay. That's okay. Can I have that 3 ml lower lock syringe?
3 ml lower lock syringe for injection, please.
Leave the contrast in it. Don't empty it.
3
Right? We don't have to do it every time, so leave it for. It's okay. That's okay. Okay. I suspect it is where we thought it is, but
Okay.
let's find out.
Okay, when you're
Screen
ready.
there, on the screen. Okay, let's take a cine.
Okay, ready?
Go. Okay, stop there, that's fine. Come to BA Codal.
P Athauda, please.
BA Codal, please. And can I have that Gladius EX wire that we had already? Screen there. Oh, it's not very helpful here. Go to LAO Codal.
LAO coral.
It's okay, one is more than enough. Screen there, okay, cine.
That is also not
Okay,
really
fine.
helping us much.
Right, come to BA Codal, that's okay. Give me
Doesn't
that
matter.
Gladius. Come to BA
Gladius,
Codal.
please.
Gladius EX. Let's take a cine again. Okay, fine, good.
Yeah.
Right, RAO Codal. And give me that female lower lock syringe again, please.
3C.
Yeah, the 3C. Yeah, that's one. See if you could open that up. Screen there for me, please. Okay, cine. Absolutely no idea.
Yeah.
Absolutely no idea. But
Still that's acceptable.
we'll have to see where we are. Yeah, and we know it's in the LED. There's
Yeah,
no question about
yeah.
this. Go to RAO cranial. Because we might have to do multiple things to see where the
Sure.
hell this is. Screen there. Unlock. Okay, let's take a cine. Okay, fine, good. Give me that Gladius EX wire, please.
Gladius. No.
Okay, talker on. Screen. Stop screening. We still have a long way to go with this one. Can you give 2,000 heparin? Okay.
2000 units of heparin.
Again, control the wire here is going to be difficult because this is a very soft catheter. It's not, but
Then adding honey then come on there.
2000.
Yeah.
dips
Yeah.
needs to go. And looking at that, let's see if I could screen now. I'm hoping this will stay pointing up. Let's see.
Change the direction.
I know, but it's where direction where it's jumping up and down. It's dangerous. Test me there, please. Can you test on the retrograde? No, test on the right. Test on the right. It's okay. Test on the right.
Yeah.
That might see something better if the guide is still in. Yeah, test. Okay.
I'll take a shot there for
Take
you.
a shot. Yes, go. Screen again. Screen. Oh God! I don't know where this has gone.
I think that's the right. No?
You think? I like your optimism. I don't know where this has gone. To be honest, I have no idea. Well, we'll have to test. I'm not gonna follow it as long as we don't follow it with the wire, whatever it is. We have no VEs, right? Which is good. We have no. So fine. Let's stop there for a second. Let's have a little test on the antigrade.
Yeah.
Test there. Are we in? Test. Okay.
Okay.
Stop. Store that.
So that please, yeah.
Store that fluoro. Come to BA Codal.
P Athauda, please.
Because if we're happy, I'll proceed a little bit further, but I need to be 100% sure.
Sure,
Don't be fooled with one.
One wave.
Yeah, it's kind of coming down. It's just funny. Let's have a little test. Stop there. Let's have a little test. Screen. Oof, I don't know where this is. No, this is not the right direction, is it? LAO Codal.
Yeah. Spider wave, please. Yeah.
And we might have to do even LAO cranial and all this. Yeah, this does not look right. Yeah. Let's have a little test. Screen. Test. Yeah, this is not right. Store that. Come back to go back to RAO cranial. You see, this is why. That's what I was saying about the stiff wires. It'll go. It'll go.
We don't know where.
But we don't know where it is, and you really have to be very careful what you do with it. So, If I could just pass it through this septal there. Again, it's just doing the same thing. Ideally, I'd like to knuckle, but it's not knuckling because of that septal. Oh my God, okay. This is very, very ambiguous anatomy. And again, this is a little different course. I don't know. Test integrate, please. Where is this going? It just does not look right.
No, it doesn't look like.
Okay, stop there. Come to LAO caudal. So the alternative, of course, that looks okay. Screen there for me. Screen. Test. Okay, it looks a little bit better proximally. Screen there, screen. It's okay. I'm gonna bring this back a bit here. Go that way. I'm steering again to the. Okay, let's stop there for a second. Go to LAO cranial.
Okay, anomalous origin of
Who knows? Who knows?
Yeah.
I mean, it is very unlock. Screen there. Test me there. Test. Test please.
Calcification is slightly.
I mean, it is.
unusual, right?
It is. Just take a cine here. Just
Yeah,
okay.
One
One second.
The calcification is slightly off.
Cine.
Yeah.
Okay, fine.
Okay.
Yeah, we need to be. It's going this way. I need to be a little bit more.
Yeah,
At least I need to
calcium,
know where I need to direct my wire.
Yeah.
So let me see if I could.
Yeah.
As I said, the problem for me, I can't control this bloody wire here. So this is why the knuckle is the safest way, but I can't start my knuckle because, again, I have no control of the wire. Don't know. Let's have a look.
Sure.
No, I'm not sure. Test.
Okay, test again.
Nah. Okay, stop there for a second. Just go back to areocranial. Okay, let's screen. Test me from the retrograde. Test on the right, please.
Sure. Yeah. You want to cine?
Yes. No, just test.
Test.
Let's just test. I want to go away from the septal, which is there. Okay, fine. So I'm gonna bring this microcatheter up. Again, with the wire, I don't. It's not a big deal if it is, kind of exit with the wire with the occluded artery. It's when you follow to the microcatheter, like I'm doing here. I'm saying something and doing something else. But I need to have some birches. Take this wire away, and give me the MG.
MG.
When you don't know the course of the artery, the safest way to navigate it is knuckle. And again, in this case, the difficulty with the knuckle is you have a left main stem, and the LAD is occluded the left main stem. You come in a subintimal space, you could compress everything, you cause a big problem. We are bleeding back. Let's just get on this. So, but we'll have to see. So what I might do, bring this microcatheter back a little bit and try to knuckle a little early on, if it works. Because with the contractility, I have no purchase on this. Okay, let's have a little test there. Sorry, let's screen that test. Stop screening for a second. Just set myself up here. Okay, screen again. So that's the septal. I know where we need to be. Yeah. See, again, this is not doing what because it's hydrophilic. So we need to puncture, but it's not puncturing through. Okay, let's stop there for a second. The wire, especially hydrophilic, is always going to choose the least resistant. So the distal cab, again, to add to the complexities at the septum. Yes. And of course, going retrogradely. So what might this end up? Because I'm getting to the point right now. We're 1.3 gray. It's not too bad. I don't know how much X-ray dye we've used. Again, still he's young. It's not a major deal. It's getting to the point where this is becoming not efficient, and it's not going to work. I don't think. So what needs to happen probably You dilate the RCA stent, get it to the proper size, which I think is probably about 3.5. Let it heal, and you could come back and then try to do the retrograde from the RCA, because it's a little bit safer than this. The control for me right now with this wire is just almost non-existent. Just doing this, and you could see how it's moving. But I'm gonna try one last time.
Yes, please. Yeah.
Let's take this. Let's take this wire away.
For them to come back.
Yeah, of course. It is. I could totally understand. Let's have the 3 mil lower lock syringe with the contrast. That's contrast. Yeah, absolutely. And this is why I'm persisting a little bit more.
Correct.
There's a lot. As long as we're safe, it's okay. Okay, let's take a cine. Okay. Yeah, okay.
There's a little here and there, so that
Yeah, it's okay. I mean, that's where the wire went. It's
Yeah.
all right. I'm not too fussed about that. Just go to LAO cranial. Let's do it in a different view and
cranial.
see what we could find. Okay. See ya. Okay, fine. Absolutely no idea. Absolutely no idea. Because it's a very funny anatomy. If we again screen for me. Stop screen. You know, the screen again. Screen for me.
So there is a little channel there, right?
Store
So
that.
that and then play at the end.
Yeah, but that could be the wire where we went. I'm not sure. Let's go back one. It is very, very, very ambiguous. This is very unusual. Okay, let's give me that Gaia next 3, please. The Gaia next. Just go back one.
Go back one.
No. Go forward. Now next one. Absolutely. This. Actually, we need to move this. I don't want him to have a bit of a rest now. Okay. Talk around, please. Go back one. Okay. Back again. Yeah. Where the hell is the? Because he's also the heart is a bit rotated.
Yeah.
This appearance sounds almost like an RAO, PA cranial.
Yeah.
And then there you'd expect the LED to be coming down here.
Yeah.
It's going that way. So he's got a vertical heart, which is also making the anatomy. Okay, let's have a little test here. See what you can find. Crucial when you throw any collaterals to make sure that you protect them with the microcatheter. You don't leave the wire on its own. This is really no control of this wire, and yeah, it's not. Just on the retrograde, please. Just from the right. Yeah, this is going veering off the screen test. Okay. Don't know. Screen there. Yeah, the tip movement is just really too free, and I don't like that at all. So I think we have to accept. So one option is I'm going to leave this wire in here, see if I could start knuckling a little bit earlier, get to subintimal space a little bit earlier,
Yeah.
and see if that would work. Of course, this microcatheter is gripped, absolutely gripped. Okay, fine, this is better, hopefully. And if that's the case, I'm going to use the MG. Take this away, please. And give me the Gladius MG.
Gladius MG.
Yeah, I think this is becoming a bit inefficient. And this is clearly not going to. So we have an IVUS now. We could go down to that stent in the RCA, do it.
Yeah.
And I mean, this is the. Okay, let's have a look at the screen, please, for me. See if I could get into the subintimal space from here. Because if we can, then life might become a little bit better, but. No, it's doing the same, going straight to the septum. Straight to the septum. Sometimes, and I've done this before, but not in this lateral. I took a balloon retrograde. Stop screening. I took a balloon retrogradely and did the base.
Yeah.
Dilated the retrograde.
Yeah.
And then got in the subintimal space that way and I did it.
Yeah.
In this case, everything is fraught by difficulty. We don't know what the oscil LAD is.
Yeah.
The distal cap is at the septal. The epicardial is so tortuous, so the control of the wires. So it's just on the GTO score 1 to 5. This is 12.
Yeah.
And
That's
I
why
just
handpicked it for you.
I know, but it's just I'm a bit, you know. No. It's. I mean, this is. I do a lot of these, but this is a lot of stuff there that is
hard,
against what we are doing, and it's just not. Oh, look, I need a little bit of luck right now. So this is why I have to turn, and it's just not turning because you could see that I'm trying to move it, and the contractility of the heart is what's dictating what's happening here.
Yeah.
So if I'm going to
It's
try
trying
to bring,
another sector, right?
it's one of these. Sometimes, okay, it's a little bit of luck in here might be what we need, because again, with the difficulty knowing what the anatomy is to kind of push a little harder. It's what's causing. So now this MG is hooked into the cab. So hopefully, I could. Come on. No, it's gone. We're going somewhere else. I don't want that to happen. Little test on the retrograde, please.
Okay.
So it's just past that septum.
Yeah.
And you can see how it's going to store that fluoro. See how what the wire is doing.
Yeah.
Because it's prolapsing into the area. Look.
Yeah.
And this is an intramuscular course proximally, and that's the most difficult part. See how it's doing.
Yeah.
So I'll see if I could. Okay. So the wires come back. Again, this is typical of what happens with the epicardial. See if this will take somewhere. Well, we don't know. I mean, it's going somewhere, but I don't know where. Okay, stop there. Let's come to BA caudal.
Yeah. BA caudal, please.
Sorry, areocranial first. Areocranial first. Let's go in there. Okay, stop there for a second. That looks better. Screen. Store that, I'm not sure. LAO caudal. Store that fluoro. Before we push the microcatheter in, and just stop. One second. That looks better. That looks better, but we're still not sure where we are. Okay, let's screen a little bit. Okay, store that.
Are we in or no?
I don't know. Absolutely no idea. Store that fluoro, please.
Play that, yeah.
Let me just get the guideliner in because I'm not sure the screen. I'm gonna take a little test again. Okay. Stop screen for a second. Okay, screen for me. Store. It's very close. Store that. I'm happier now. Okay. Come to. Actually, let me just advance this a little bit more, and then I redirect from the area. Don't come back. I don't want the wire to come back. That's subintimal space. No, that's subintimal space. This is going, but I just need to advance it just slightly. I get away from that septal, and then. Okay, go back to areocranial. Oh, look at the wire. Yeah. I know. It's all the pressure because the screen there. It's the. Test me on the antigrade again.
Antigrade again.
Yeah, best.
I think it has to.
It's very close.
Yeah,
very
it has
close.
to go straight, you know. Yeah.
No, but it's not. So if I could advance this microcatheter again, this is where the finer cross becomes a problem because it does not have the oomph to go through that distal cap. And it's you can see I'm putting a lot of strain on the epicardial. Yeah, so the caravel, and we're having ectopic, so because there's a lot of strain on that epicardial, to be honest. Trying to push through. And of course, these wires are going to continue to go outside because test there, please.
No.
Yeah, it's not. Yeah, it's need to turn just around here.
Yeah.
And
then
of
hit
course, I
vertically.
can't control it, and I can't get that the microcatheter. This is we need a caravel now instead of this to be able to. And if I'm honest, I'm not gonna change that if it doesn't go. What's that beeping, guys?
No, don't worry. It's just the background. Just switch that off, please. That's the battery pack.
Yeah, let's test retrogradely. I want to just get this microcatheter just away from that septal. It's gone through that area of the septal. So, okay, let's stop there for a second. I am going to be a bit braver. Take this away.
Yeah.
And I'm going to use the guy in X3. At least
Guy in X3.
Yeah. Give me the 3 ml lower lock syringe. The other one full. Thank you. Screen for me. Let's store that.
What is that?
Vein. Come to BA caudal.
Carbon?
Yeah, the
Got a
back.
track, yeah.
Yeah, with the wire. Okay. Yeah. Okay.
Dissection?
Yeah, dissection. Okay, store that again. Can you give me the cyan? We have a cyan black, right? Give me the cyan black. No, I don't want the cyan. The guy 3 now. I just need the cyan black.
Cyan black. Cyan black.
Yeah, I mean, I think I'm still not 100% sure. It did come through, but then it curved down. It needs to be going toward that area of having some ectopics. I think it might be. So I said it maybe just do the RCA and leave it. This is another attempt with the RCA because I'm having difficulty. This is, and now the more you try to, it's putting strain on this epicardial with the tortuosity. You can avulse it. Can I have a fresh cyan black? Just give me a fresh. Is this the one? No. The cyan black, yeah. That's just melted. That's okay. Okay, move the top up, please. Okay. Spin for me. Ah, look at that track of the contrast.
Yeah, that's what I meant.
I think and I don't like either. But go to arachocranial. But it's okay if we could. Should
you protect the antegrade cert?
Yeah, that's not a good. That's a track. In the. Sometimes when you do this,
you might be able to find it.
That's the HDR. Must be called the HDR. Let's test antegrade.
Okay.
Antegrade, yeah. Antegrade test phase. That's what the HDR, but that's okay. Store that.
Yeah.
Okay, we could bring this microcatheter up. We're gonna have to stop here. We could be causing problems. Screen there for me. It's not going in. No, it's not engaging. Anyway, let me just see. Go to LAO caudal. Yeah, this is not.
Not good, yeah.
I don't think it's the pericardium. It's all so it needs to turn. Let's see if I could get this into a little bit more. Okay, that's jumped through the left main. So that it is there. I know. It's just so disappointing. But it's just the course is absolutely. And I don't have any control of this wire again. No, it's still not going the right place. It's turning to the other side here. Yes, it's a little gentle test again on the integrate. Very gentle, really, really gentle. Very gentle. Test, Jerry, very gentle. Gentle, okay, that's fine, okay. No, it's not turning into it. This is turning around, okay. Can I have the Gladius EX wire?
Gladius CX again, please.
Take this one away.
Okay, sir.
Yeah. One last attempt. If it doesn't go, we'll have to stop. Let me move this away. Let him drink some. Okay. That's not the Gladius CX, guys. That's the Gaia.
Gladius CX.
That's the Gaia.
ये गाया कभी लोग ये No, that is not that. That's XTR. No? Yes, Gladius CX. Is that XTR?
No, that's not the Gladius CX. I'll try this one. It's okay. No, it's not. It's not the Gladius CX. But anyway, I'll try it. I just need something slippery. This is the second EX. I don't think it'll go. So okay, talk around. Can you try while I'm doing this? Can you try to find the Gladius CX wire?
Gladius CX wire. Can I go on?
Okay, screen is going. So this is the Gladius. This is the Fielder XTR. I don't think it's gonna work. But who knows? We might be lucky. I don't think our luck is good today. Yeah, it's not gonna work. So let's not waste time. Did you find the Gladius CX?
Yes, sir. Yes.
No. Okay, take it away. Take this away, please. And of course, the microcatheter is coming back with all the contractility.
Yeah.
So we might lose that place, but that's okay. Okay, talk around. Stop screen for a second. Talk around. So again, I mean, you look, these cases are not the most, this is really one of the most difficult ones because everything's ambiguous. And in the same time, they're not something that's going to happen in a few minutes. This is a lot of work. Take me to arachchi first before we do, just to see, because we've come back from the septal. So I might have to reintroduce this again. Screen for me. Yeah. Look at that track that we created. Again, there's no panic here. Everything's okay, and the arc is still blocked, so we're not. Yeah, this is again resistant. What we gain has been lost with the contractility. Come on.
Yeah.
It's following the same track. I don't like that. Okay, back to LAO caudal.
Yeah.
Okay, now the screen. It's not going straight. It's bending out, and that could be what causes the issue. And IVUS is not going to help me here. Test me there, antigrade.
Antigrade check.
Test, please.
Antigrade.
Okay. It needs to turn up. Okay. I think this is time to stop because I can't see, and I don't want to take the Gaia 3 because I think we could be running into trouble here. Yes, this is not even moving forward. We lost what we gained. Come on, the bugger. I mean, I'm intra black because I could feel. Okay, little test here.
Little tester, please.
I don't know. I'm not sure.
It's turning into the
no, I
side,
know,
no?
but it's not.
Yeah, it is.
I know, but that's not. Okay, let's stop there.
Yeah.
Let's stop there. Go to arachchi. I've never seen a case where you don't see what the ostial. Test me their antigrade. What the ostial LED is. Okay, let's just see. This looks a little bit better.
Yeah.
a little bit better, but I don't know. Still all.
Okay.
This is only, you have one VE now. Okay, stop there. Go to LAO Kodov.
The call, please.
Oh, hello. Okay.
Antigrade check.
Just 1 second. Let me get this a bit. Come on, stop. Because now we're subintimal there. Test there. Test. Gentle test again. Gentle. Okay, we're very close. Fine. Now it's time to take the IVUS, probably. See if I could.
You might be able to see the
I
tip of
don't
the
know
eye,
if I'll be able to do it with this guiding catheter because it's 7 French and we have a guide liner in or telescope with the rod. That's not going to allow me to do anything. Yeah, it's not turning here. I need to turn it to the other side and it's not turning. If it turn to the left, we might be in a better place. Come on.
You can do it.
Come on. No, it's not doing it. Let me just see if I can advance this a little bit more speed for me. Again, as I said, okay, that's better.
Okay, that's better.
Better, but I don't know. Test antigrade. Okay, that's enough. That's fine. Okay, no, I'm not sure. Okay, go to RAO cranial, quick. Okay. Store that. See, I didn't touch the wire. The wire's coming back just by. Okay, take this away. Come back to LAO Kodo. Can I have that guy in X3? A little closer. I don't think I'll be able to put the. I'll be able to put the guy next 3, please. But look at the tortuosity and the anatomy. Why are you changing the table height?
Don't change.
Why are you changing the table height? More X-ray. Let's hope the microcatheter is still in place. Okay. I need to bring this guide liner back a bit. So we don't have little test here, please, on the guide liner. Test.
Okay.
Test. Gentle. Okay. Fine. Store that fluoro. Okay. Yeah, look, I'm not doing anything. Look at the wire. With the contractility, but it's not. We still have to turn around because this is absolutely. Of course, now this is very resistant with all this tortuosity, and we're putting a lot of strain on this epicardial bot. If I could bring this back a bit. Oh.
No, don't come back.
No, I brought it back because it's just too dangerous there, especially with this guy in X3. No, it's going the opposite direction. That's the problem. It's the software is doing okay. Okay, take this one away. Give me the Gladys EX. So close yet so far, right? Gladys EX, please.
Yes.
Gladys CX.
Move this away. How long since the heparin?
Guys.
Or the ACT? How long, guys?
ACT was at 10:45. Or what was it?
Yeah,
45 minutes gone.
I think we've taken a lot of time on this, and I think it's time to call it a quit. We're coming to 2 gray. We're almost there, so which is the Gladys CX. Guys, Gladys CX, please.
Sir, can you see before?
That's the field. That's okay. I'll use that for the rest. Yeah.
Please
That's the MG. No, that's the MG probably. Talk around, please. Yeah, that's the MG. That's just fine. I did do the trick before.
Same.
Yeah. because we lost it. We didn't. And this. Test there, integrate, please.
That's the integrate.
Okay.
Okay, that's fine. Okay. Yeah, see, now it's turning. I need the EX, please. Can you find the Gladys EX?
Let me see.
Yeah,
That's again the same track.
Yeah, no. Back to cranial, please. Yeah, that's the one. Okay, take this one away.
The micro has come back.
Yeah, I know, it's
yeah, that's the problem.
it's okay. It's okay. Yeah. Talk around. I said so close yet so far. And I think this is not, I'm not hopeful now, looking at what's happening here with all the, okay. So now it's going to start getting hooked into that septal again because it's starting to do the same. No, no, this is becoming, okay, I think we have to stop.
Yeah, it came back too
Take
far,
this,
right?
take this one away. I didn't touch it.
Yeah, I know.
It's just with the contractility, and we lost.
Plus,
Can you
plus
give
the-
me the soft wire, maybe the Fielder FC? Or
Field
the,
FC wire.
No, sorry, we don't have Fielder FC.
Xeon Blue.
Just give me, no, I'll take the Fielder XT. The Fielder XTR.
Field XTR is.
Yeah, the one we use, because we need to make sure. And this is now the crucial part about this. So what we need to do, leave the wire in, we bring the micro catheter, take a picture, make sure the collateral is intact.
Yeah.
Before we spend a long time. If you move your wire and your micro catheter without protection, if there's a problem getting into this epicardial subdivision, unlock here. Unlock the table. Okay. Screen for me for a second. Okay, good. Yeah, I mean, it's a shame, but that's it. This might still slip through. I'm going to try it one last time, because I am absolutely gutted that we've got to this stage, and yet that's going to the septal. Maybe it will find the track that the previous wire did. No, it's not. It's finding the... That's the original track.
Yeah.
Can I knuckle? That's going to the septal, right? I think we've exceeded. Oh, it's too grey now. So I think it's time to say I tried and it didn't work anymore. Yeah, this Fielder XTR should not be doing this.
No.
It's subintimal space there, big space, and I think it's not. Yeah, okay, fine. Right, so now we have to do this gently and slowly, so we could keep it in place. I usually, okay, I'll leave the wire in place in case we. Okay, so we're gonna get this guiding screen there for me, so I don't want to lose the wire. I'm gonna take a picture to make sure that all the collateral is intact. Okay,
Retrograde as well, or?
No, just take a screen.
Okay.
For me. Okay, stop there. That's good. So retrograde is intact. I'm going to bring the wire back against screen, please. Okay, take another cine. Wait 1 second. Okay. No, yeah, no, my guide is, everything is in. Just 1 second. Screen. Okay. Cine. Okay, all good.
Okay.
All intact, so we're okay for this. I'll take this away, please. You can stop screen wait 1 second. I'm going to do one without the wires. I don't think we need to do anything with this screen there. Okay. Fine. So, everything is okay. What we caused with the wire is not an issue.
Yeah.
Okay, let's pull this back. Let him drink his... okay. So, I think we're here. Let's just do the RCA.
Yeah.
if you put the IVUS there and post
Take a
dilate
look and
it.
see. Yeah. Okay.
And maybe if that happens for
Yeah.
the next time, you're gonna find if there's a next time, going from the right coronary artery might be an easier thing because you avoid. Although looking at this, whatever you do, you're still gonna come through the before that first septal. However, because you'll be coming straight and there's not this this as expected because all the lateral collateral is always very
Sure.
I don't think you find too many people going through this lateral or choosing that, but
Yeah.
I've done many of these and I would have hoped to kind of dissect a little earlier, but it's not
Yeah.
possible. Just go back one, make sure that we're
Should we take another view in the PA caudal?
We
just to
can,
make
yeah,
sure,
yeah.
Because
Yeah,
it's,
fine.
can the
the ostal left main needs attention another time, but that's come to
Keep
be a
on, please,
caudal,
yeah.
it's always better. I think it's all okay, but
because you saw the hematoma earlier on.
yeah, but that's
it might settle
all.
down.
It
because,
will settle down. There's nothing there to.
Yeah.
Okay, fine.
Yeah.
Okay, good. It's just because remember when you're injecting through the microcatheter,
It's in the opposite direction.
you're generating a huge pressures. The jet is coming out, and this is what we saw.
Yeah.
I think we're good. Let's have a look at the right. I
Okay.
think finish out of the left main. So he's okay. Fine.
Let's get the IVUS down to right coronary artery, please. IVUS back again. Flush and give it.
Yeah, it's one of these that. But again, I said not too many people will use this kind of epicardial. Nonetheless, the limiting thing on here. Yeah, let's take the IVUS.
Yeah. So for the viewers online, what you said is we managed to get almost to the end of the distal cap, but unfortunately, the very last bit, we are unable to get through.
The difficulty on top of all this,
Yeah.
I have no idea where the LAD ostium is. So
Yeah.
I cannot do any antegrade work.
Understood.
And as we said, the difficulty when you're going retrograde, and I was a bit hesitant to generate the knuckle because if you knuckle back toward the left main stem,
Yeah.
you could easily compromise these open arteries. Unlock the table. This, okay.
LAO, please.
Yeah, shallow LAO unlock. Move the table across. Okay. So you could easily compromise the intact arteries because the hematoma, when you come subintimally, okay, unlock. Move the table towards me. Move the table this way. Move the table this way. Okay. So I think you will probably be hopefully through the struts, through the lumen. Just 1 second. This needs to read. You might need to push your wire further down. Bring this forward. Bring it forward. You have it because this is distal RCA. Keep coming. Keep coming. Keep coming. Go on live. Let's have a look and see because the proximal part was quite diseased anyway. So need to flush.
Flush, please.
Where is the flush? No, in here.
Here, the
On the
IVUS. IVUS catheter flush. If you need to clear the. Yeah. Okay. All right.
Okay, so let's go
I'm going to take it
distal.
down.
Yeah.
Yeah. Let's see
Keep
whether,
going. Push this on.
whether we go through the stent struts or not.
Oh, well, let's find out. Well, the microcatheter, but that doesn't mean it's not. So again, this is at least 3.5 distally, and now it's becoming. Let's see. Here's the
A
wire.
bit of
through
resistance,
lumen.
to even advance that.
So it may be again we've gone through the strut and although it's not. That's okay. It's gone a bit, hasn't it? Yeah, it's gone. Let's push this on. Let's push this on. Keep going.
So the distal end of the catheter is down there. But
No, it's not the IVUS though.
no,
The tip is through, but not the IVUS. See if you could get your guide a little bit further because we've got no support from that guide.
Okay, so we go.
And let's have a burst of cine. Do we see? Is it going through the stent? Do you have a stent boost?
Stent boost, please.
Yeah, unlock this. I don't know if we're going to see it. In fact, unlock. Just a second. Yeah, let's try then. See, I don't see without a balloon, maybe, but let's try it. You can see. Okay, it'll be okay. It doesn't look like it's. Looks okay.
Okay.
Let's see if it'll
Keep
go.
pushing.
Yeah. See if it'll go.
Get the wire down as much as possible.
Yeah. No, it's not going, is it? It's not going. Yes, unlock the table.
Okay, I'm
That's
going to
not
top the guide in
Well,
as much as possible.
If not, yeah, just use it as a guideline and push it all the way down. Turn it clockwise and push it, it'll go down. It's come back, your wire's coming back, your wire's coming back. It is through the... I'll tell you what, just take a balloon and see if the balloon will go. If it doesn't go, then you don't dilate because it
Yeah.
may well be. And even if you take a 3.0 or 3.5, you'll be fine. Yeah, fine.
Yeah, okay, so difficult in advancing the IVS, that's okay. So
I mean, a body wire might help.
Yeah.
You're getting no support from that guide at
absolutely,
all.
yeah. Should we put a body wire? on
You
the-
can, but
yeah.
I think you need to take a balloon and see if that will
Okay.
allow you to...
Yeah.
fine.
3O?
At least to start with, yeah, start with the 3.0. Take
3O
this away,
balloon, please.
3.0 15 non-compliant
3.0
balloon.
Up the one, yeah, we'll be moving
It's
back.
not going to take,
Yeah,
you know,
yeah,
okay.
Just, just over
So
there.
if
but-
you put some guy, oh,
Yeah.
as I got in a subtle. Sometimes what happens, you know, honestly, it's just crazy. Sometimes you just need some luck.
I know.
There you go. You could.
how
I'll
difficult
go out
is
and
that?
you
Yeah,
finish
let
this.
me just,
You should have done it from the start yourself, yeah.
No. Still not in the right place. Yeah.
Who knows what it is? It's.
Yeah.
Yeah, I think the proximal part might be.
Yeah. 3O 15. 3O 8. Okay.
Well, yeah. I mean, you lose some, you win some.
Yeah.
But this is just, as I said, it's one of the toughest cases because I'm still, this way up to now, I'm still not 100% sure where the osteo LED is. It did look like just around that area, but who knows? And yeah. And again, I mean, with doing CTOs, particularly these cases, there's a lot of, the simplest of cases sometimes could tend to be the most difficult. And yeah, we've seen where the epicardial is, but going through the epicardial is always very challenging.
Yeah.
To cannulate them, number one, particularly with the right wire. Secondly, with that contractility of the heart, your control becomes very difficult and very demanding. And when you're using stiff wires, you have to think about the safety and about whether, okay, let's see if this will go through it. It's not going, is it?
And that is a little bit of challenge.
So I wouldn't dilate it. I wouldn't, because you're probably
You're
going
not sure. Yeah.
through, going through the strut.
You want me to try to see whether we can rewire it?
Well, you can.
Yeah, why not?
Because, I mean, you know, this is your best, you know, okay, that's better.
That's better.
That looks better.
Yeah. So
That looks better.
hopefully this should. Yeah.
Yeah,
it'll be
that looks
So
better.
that's
So it was going through a strut.
Exactly. Yeah.
And that shows you,
That,
and now-
that shows you how it
Exactly.
was.
So I think you'd, yeah, both dilate this because
Yeah.
I think it's
Boost, please.
a 3.5, but a 3.0 at high pressure should be fine. Yeah, way inside it, that's
Way
okay.
inside, yeah.
So you
Shall
could
we
go a
down
little bit
this
further.
level?
Yeah, you need to go see where the radioback segment, just a little bit before the radioback segment. Yeah, okay, you're
Okay,
inside.
Go
Go
up.
up.
Go up, please.
Go up.
2, 4, 6, 8, 10. Go up to 10.
Yeah, just go.
Minimum 10.
Go
Okay.
higher. Go 12.
12. And down. That's way down.
Okay.
Down.
Down. So even the IVAS now might go. Okay, go
Go
up.
up. 12. And down. That's okay. Okay. Go up. 12. පොඩ්ඩක් එක්කම දැන් බය වෙන්න එපා. අර කලින් ස්ටෙන්ට් එක හදනවා. 12 and down. Thanks. Okay. Down. Yeah, go up 12. And down. Thanks. Okay.
You're still inside.
Yeah, go up. Go up.
Couple
I can't
balloon,
see, you know,
couple balloon dots to go. So
12.
go to 16. Give it a big.
Okay.
Yeah,
Down. Down.
here we done the strut, the micro catheter.
Can I see a little bit more? It's just I can't see anything with the. Yeah.
I mean, it wouldn't matter to me because the arc is much bigger. The 3.0 will not touch.
No, it's out.
Will not touch
Out.
this side.
Okay, no, see, no, too far. Yeah, go up there, please. Yeah. Still need to do the proximal strut, but that's okay. We'll accept this. 16.
Go to 16.
Yeah, so that's hugely undersized. That's right. Down, down.
I mean, I think even 3.0 might not be enough,
Yeah,
but
exactly.
but you
we
could,
can put
maybe
the
the
IVUS
IVUS
down and then do
could go
IVUS
down
guided.
now.
Yeah. Okay, try 50 down.
Even if it's outside of the proximal bit, it's not going to touch the side.
Yeah, 2, 4, 6, 8, 10, 12, 14, 16.
Yeah, go.
And down, that's okay. Down. Okay. Right, so that is freely moving now.
Yeah.
Okay.
Yeah. You show that the wire did go through. And
Yeah.
the fine cross, thankfully, it's just not, shouldn't cause much issue. So let's take the IVUS and
I
see
was
what
down
happens.
again and just take a look. Okay, I came back a little bit. Okay.
There you go.
I don't know.
Surfing and it goes. Well, that's what happens quite often because that's the surfing of the.
Serendipity.
Yeah. It's on a small branch actually. It's
I
outside.
can see that. Yeah. Okay.
That's fine.
Right, let's get an IVUS, please, again.
And I think this is a very educational case. If you're interested in CTO, so basically with what we try to do, the safest option, i.e. the septal.
Yeah.
We were faced with lots of problems because you've got an undersized stent, the wire has gone through the. That's what I was saying. Even if we would have gone through the septal, maybe advancing that microcatheter later on might have been quite difficult. So we tried to see if we could post dilate it. Then we switched to the anti-grade with the IVUS, and that did not help because it's just the nature of it.
We couldn't define it.
Often with that calcium, which we don't see in angiography, and that's also another important lesson. Only 50% of calcium can be seen on angiogram.
Yeah.
Even severe calcium, sometimes you might not appreciate it.
Yeah.
But that's the second safest option. Now we've done this. Yeah, now it's going, isn't it? Yeah, okay. So it was through the strut, wasn't it?
Still there.
So again, you could see there. I mean, you don't need, look at the artery there. It's about 4 millimeter, right? Okay, if it's not, I mean, you could take the guide liner if you want, because that will take you through, and that will allow you also to assess the proximal part. Okay, here you go. Here you go. You're inside. So it's 3.5 would have been.
Yeah. So focus on the.
But that's okay now. Just okay.
It's not too bad actually.
Not too bad now. Still, I mean, here it is really small.
Yeah.
There's no question. For me, I would take a 3.5 or a 4.0 at low pressure. 3.5 to be safe.
So there's 10 malapposition, right?
A lot of it.
A lot of it.
A lot of it. And what about the proximal part? Have we damaged it? I think with the post dilatation, let's bring this back.
Yeah. Okay.
Let's do a run back and see what happens.
I'll try to get it down as much as possible.
Okay, yeah, if you could exit.
Proper.
Again, you could still see that it's a bit undersized. There's a lot of calcium distally. Yeah, I mean, this is, it's well opposed, but it's undersized. That's okay, that's fine. Let's just do the pull back and see.
Pull back, please, yeah.
Do the pull back, okay. Okay, so.
Okay.
No, this is not pulling back. Stop.
Pull it back.
What's happening here? Okay, go on live. Go on live on the. Okay, let's go on live. Okay, let's do the pull. I'll do the pull back. Let's leave it. Okay.
It's pulling back, right? Yeah. Okay.
Yeah. So again, look at the size of the artery on the side of the stent.
Yes. You can see that the intimal,
I said the right coronary artery hardly changes, but and when you look at the proximal, but it's at least a 4.5 to 5.
4.5, yeah.
So you could tell immediately. But again, when you come with an acute MI, it's always vasospasm and difficult to.
So there's a big plaque burden at the proximal end as well.
So we could stop this now, and let's just go back to the proximal part if you want to assess it.
Yeah. So
I mean, the IVUS might make you do it, but I think for now.
So
okay, let's just start from there. Go on live again. Okay, here we go. Okay, let's do a pull back. I'm going to do a pull back here. Again, it's a 5.0, as you expect. You could see it angiographically.
Okay, so
here you go.
It's.
So this is eccentric calcium, deep calcium. Cross-sectional area, I think here would probably be okay, but here it is more
Yeah.
is tight here.
Yeah.
But here you go, tight.
Yeah. Yeah.
Whether you want to do, look at that. I
I
mean,
think we probably should do the right at
I
least,
think,
so
yeah.
make it perfect.
yeah.
Then leave it as investment, and then
Yes.
come back
And
another
then
day
see
and
if
fight.
it's
Yeah.
still symptomatic, and
Yeah.
then you come back, and hopefully now that it's all. But I probably would I still take a 3-5 for the distal part of the stent and just do it. So if you come back again,
Yeah.
there's no chance for the wire to go through the
Yeah.
strut. But proximally, you could see it. I think you probably need a 4-5
Yeah.
by 28,
Yeah.
and that
Yeah.
will.
Yeah. Okay, we'll
and then
stop there, please. Yeah.
Use the 3-5 non-compliant balloon
Right.
for the stent distally.
Okay.
Yeah, I mean it's like 1, 2, 3, 4, 5. A 4-5 being
So we
conservative because of the
correct.
calcium, but
So shall
think
we,
it's
for the
needed.
distal one, do you think we should take as 4 and then use that as a pre-dilatation balloon for the proximal RCA? And then,
yes, yeah, that's probably the best thing to do.
Flush that and keep it. Yeah. Okay. So shall we have a 4 balloon, please? NC.
And the 4 for the distal part, I mean, distally you could go to 6-8 atmosphere,
And
approximately to 10, 12.
Yeah.
It's all good, and then
Use that to do a pre-dilatation at the top end.
Pre-dilatation. Yeah. So it's all deep calcium, so I think it should open up nicely. Yeah. Yeah, so going back to what we were saying, so we went step by step, and okay, the last resort is that the epicardial, it was the only resort after all what we found. In normal circumstances, using the IVUS will help you. I say normal circumstances because in the majority of cases when the CTO, there's calcium, fibrosis, and you put the image and I'm like, okay. And the most unfortunate thing in here is it's a flush occlusion of the ostium.
Correct.
Where is it? It's a very unusual not to be able to tell where the ostium is. But in this case, here we are. It's just
And it's not possible to do
even retrograde.
There's no way.
I couldn't do any antegrade work because and even retrograde taking the Gaia X3, I was a little bit more comfortable doing it, but it's still not a very safe thing, and we could not initiate any knuckle because also that's dangerous in these cases. Being flush occlusion, if you cause any if you cause any hematoma in the left vein, you run the risk of losing one of the branches.
Absolutely.
So as I said, it's really fraught with difficulties, but nonetheless, it's not impossible. Okay, we struggle a little bit to get through the epicardial because it's not the right equipment, but do cases. The more cases you do, the more skills you develop, and you should be able to handle many of these cases. And it is that kind of perseverance and skills that you need to develop to be able to handle the majority of these cases.
Okay, so let's use stent boost to guide us, but
yeah.
Let me get it down a little bit more if I can. But,
if it doesn't go, you could just inflate it in that area if it's within the stent, and then you could advance it a little bit more.
Yeah, I think I did. Yeah, okay. Okay.
Yeah,
so,
okay. So you could just go a little bit further forward, so you could. So you could see where the radio big segment. If it's not going, you could go up there. That's fine. Go up to 6 or 8 atmospheres only, so you don't cause any problems. If it's not going, that's fine. Because once you've inflated it, you should be able to push it on. Yeah, it hasn't moved.
Right. Yeah, moved a little bit. Yeah, 2, 4, 6, 8, 10. I think once the proximal.
Yeah, that's enough. Okay.
Okay, and down. Okay. See what I can.
Okay.
Move in the same manner. Yeah, daughter it a little bit more. No,
it's okay. Yeah. That's fine. I mean, it's
let's do the
once you've done it a little bit more, you might be able to do it after.
Go up, 2, 4, 6, 8. And down. Okay. Yeah, go up there, please. 2, 4, 6, 8.
So yes, I mean, it's
okay, and down.
One has to learn that you don't win everything, and you try. And the more complex approach you take, the more risk you carry. But if you have the experience and the skills to be able to deal with it, it's not an issue. And you need to know when to stop.
10.
That's the most important thing, I think. Know when to stop. Yeah, that's a perfect.
Yeah,
That's
okay,
a perfect
go,
place.
Go.
So you could see the difference
Yeah.
even when you both dilated
Exactly,
and proximal
exactly.
part. So
10 to down.
Oh,
Okay, down.
fine.
Okay, let's see whether we can get this down further.
Yeah, so it's moving now that you've lost the
the resistance,
yeah, exactly. Despite being it's still in the same area actually, but it's not going to that. So that's where you dilated the first time. So it still hasn't crossed to the distal edge. Yeah, it's still stopping in the same area. What might be helpful if you go up to 6, when it's coming down, you push it
Yeah.
forward.
I'll try once more. If it doesn't, then of course we'll try that trick. Okay. So go up to 4 atmospheres. 4. And come down. Come down. Okay. Let's see whether I can glide it. Maybe a body wire might help.
Yeah, because let's move. Has it crossed? Don't think so.
No, come on there.
Screen, yeah, little. Has it crossed?
No, it doesn't. It doesn't.
I think it's still stopping at that because you can see
yeah,
the stent is all dilated except that part.
See, look at them. Why?
Pressure is a bit low. Can we look at the test, make sure that there's nothing there in the right coronary artery? No, little test because you're going to test there. The guide is out.
Yeah, he's having
so just because 4 or what, you just make sure that the distal you haven't caused any issue with the right.
Makad. Tuba Ramarui.
Yeah, just
coronary clinic balan put
distal right. It's all good.
Okay, that's in a smaller branch, right? So cranial, please.
Let's get some fluids running.
Yeah.
Let's just get some fluids running, guys.
I think the proximal lesion, is also causing a little bit of a problem, right? Okay.
Yeah.
Yeah.
Yeah, just put the pressure fluid. You could, I suppose, you could open the flush on the arterial line also.
Okay, on this one, I think that might be
on the femoral one.
Yeah, femoral one. Yeah.
Yeah, open the flush, give us some fluid, and yeah, I think it's just postpartum.
I think the proximal lesion is also causing a little bit of.
Yes, of course.
Yeah,
of course. So might as well dilate it, I suppose. You could leave that bit of the stent alone for now. You could, because pressure is a bit low.
Should we, come and do the proximal one? I think that might get the flow back a little bit, and then hopefully for that pressure support.
Give some atropine. Yeah, because it's all vasovagal, I think.
Yeah. 2, 4, 6, 8.
On top of that, yeah.
Okay, it's
Give some atropine. It's on bradycardic. I think it's all that.
Yeah, no. Okay. Yeah. 2, 4, 6, 8.
okay.
Down, touch it down. Okay. Up 4 mm balloons ගන්න stent plastic කරගන්න. Length එක. Yeah. 2, 4, 6, 8. Approximately section.
Yes, sir. 4, 8.
Down. Okay.
Where's the pressure? Give some atropine, please. Because it's become bradycardic. That artery is huge. It's a bit compromised. So he's gone into atrial fibrillation, has he? No, he's come back. Okay, fine. That's okay.
Here, length එක? 24. I think that should cover from ostium to mid.
You don't need to go to the ostium, to be honest, because you've got a decent proximal part. Okay, pressure.
No, but with the catheter, I think you're engaging it. I just wondered. Yeah, let me just check. Okay. Now look. I think there's a little bit of. No, it's not. It's okay.
Sluggish flow. Yeah, so where that branch comes in, this is what you need. So I think you need longer than 24, to be honest. You need longer than 24.
28, 30.
This is a huge, and of course, with the distal dilatation,
Yeah.
this is all nano flow.
Yeah,
which
yeah,
is,
yeah.
not unexpected.
Yeah.
Just go back one. Just go back one.
430
Go
එකක් මගේ
back
ඇති
one.
මේ
No, four.
430 එකක් ඇති අතන.
Yeah, I mean 24. Just go. Yeah.
24 might do. Just about.
Just. I mean, you might miss, but you could try it. It just.
There's a 30 I think.
If you go. If you stop beyond.
Yeah.
Start from beyond that little branch,
Yeah.
you might get away with the 24.
Yeah, short.
Yeah, fine. Yeah, okay. Take it.
Then a 24 එක දෙන්න තමයි. 24 කරලා දෙන්න.
Just because when you dilate it, it
Yeah.
looked a little different.
Yeah,
Okay.
yeah.
Pressure is better.
Yeah.
It's all vasovagal because of
Yeah,
the
yeah,
flow.
yeah. Come on, 24 again.
And heparin is okay, right?
What was the last ACT please, guys? 11:30.
It's
500.
okay. That's fine. We're good. We're good. We're good. Which stent is this one?
This is Yukon.
Yukon, yeah. They're quite good. I like them. Yeah. We did the registry also. There's the European registry, well, actually, international registry.
Okay.
Very deliverable, very nice. The only thing is a little is the visibility is not as
good
but
as well.
the deliverability and the how it behaves are really good.
Okay.
Okay, that looks in the
Yeah,
right
that's
place.
okay.
You could
Too
come
far.
back a bit.
Too far. Yeah. A little bit better.
Oh, that looks okay, guys. Yeah, I think that looks all right. Hopefully.
No,
You
need
could
to
still
come
come
back
back a
more.
bit.
Yeah.
That's it. Yeah, good. That's it. That's it.
Even a little bit more. I think that might be better.
That should avoid the. Yeah, that looks about right.
Just a tad more. Yeah, just
You
a bit.
could come back a balloon dot more just to kind of cover that area.
Yeah. Okay. Go up. 2, 4, 6, 8, 9. Okay. Leave there for the moment. Okay. Right. Okay. There, this is disengaged. Okay. Right. Pressure is okay. Right. And down. Thanks. Okay. Down. මොකද්ද? අකට පන්නයාගේ පපු කැක්කම තියෙනවද නැද්ද? දැවිලා කරේ තියෙනවා. හරි. අපි ඇඩිෂනල් ස්ටෙන්ට් එකක් දැම්ම එක පොඩකින්. Based on what we saw on IVS, this has to be a 4.5 at least minimum, or even a 5, right?
Yeah, absolutely.
Yeah.
Absolutely. It's a huge artery.
Yeah.
Huge artery.
Okay.
Perfect.
Fine.
That's
Okay.
much better.
Yeah.
The only thing is whether you could deliver that because this the part of the stent still a bit.
Yeah.
But,
So we'll force dilate the proximal one,
yeah.
get it optimized, and then try to pass the 4 again
And
down
see
to the
what
distal.
happens,
Yeah.
I think this is
4.5.
yeah.
Please.
No. Is the flow is much improved
Yeah,
and
yeah.
also. And I said so the collaterals now might be completely different later on
Exactly.
from the right. It's
Hurry,
still
okay,
very
bye වෙන්න එපා.
troublesome.
අපි උඩ ස්ටෙන්ට් එක දැම්ම දැන් ආර්ට් එක open, okay?
It's still going to be troublesome because
yeah. Hurry, pressure on that, okay? 4.5, okay, 4.5 then. No, there is 4.5 right then. Yeah, fine. Okay, right, okay, good. Kita kira tiara. Right, hold that. We go into 8, no? It's okay. We can manage that. Goes, please. Right, okay, yeah. Go up 2, 4, 6, 8. And down, that's okay. Yeah. 2, 4, 6, 8. And down and down. Okay, 10. You're within. 12. Okay, and down, that's okay. That's the last start. Can't see it properly.
Yeah, I think you're just inside. Just inside it. The dot could come back. You could see the dot inside the stent. Just
Come back a little bit, you think?
just a balloon dot. As you can see where it is now.
Yeah, we had come back a little bit more.
Yeah, the dot's still inside, but that's okay, I suppose. Okay, that's
Yeah, okay, we'll accept that.
yeah, okay.
Go. 2, 4, 6, 8. And down. Okay. Okay. Right, let's take that 4mm balloon back again. See whether we can go down. Okay. Cranial and but we wire to lantern this again. Okay. Distal pen and distal blur, distal pen and distal pen and distal and that. Okay. Right, that's fine. So let's take the 4mm balloon, please. I'll try to post valid this initial stent properly. I call them. In the Bawa ini Pak, bawa ini Pak, ini pada kini. Ini gitu. Full on track पर अपने की ओर कराना है, okay? Still the same. Body wire, please. Second wire. Let's see whether the body wire support we can get it down. Huh? How they will in I think how they will. Kalau tayo lang, ay natin ito maganitik na gin eh. Kahawit eh. Oh, gin na gin. Kahawit ito gin. Ano siya sa ibig? Kahawit ito kalay ito masih ano siya sa gin. Di mo ba? Ano ka ha? Kahawit ito gin na gin. Kahawit ito. Mana siya naman puron doon ay kahawit na. Okay. Okay, right. So body wire work. Yeah, okay, I think we're good. Yeah, yeah, go up there, please. Yeah, 2, 4, 6, 8.
Okay, sir. 8.
And down, touch, go down. Okay. Go up there, please. 10.
10, sir.
And down, touch, okay. And go up again. 12.
12,
And down, touch, go down. Down. Okay. Okay. Right, so let's take a pic. Yeah, yeah. Just show the part. That's the most important thing. Okay. Okay. RO, please, we'll see for investment purposes, we'll have a look and then see. Yeah.
Well, they should develop much better.
Yeah, yeah.
That's where they're coming from.
Yeah, yeah.
Still, honestly. But that's not unusual for the right.
Yeah. Mm-hmm.
See,
Yeah.
that's one of these branches. Anyway.
Yeah.
So they're much better even now.
Yeah.
So coming through these, you avoid that
Yeah. Yeah.
back
Yeah.
and forth, and which, if that's still something an option, and that connects to a diagonal, the epicardial one
Correct.
connects to a diagonal,
Correct. Correct. Yeah.
which is again could be another option, but that's a too long
Course to. Yeah. Yeah. Yeah.
You could navigate it, it's not an issue. The difficulty is the distance.
Correct.
So, however,
Yeah. Yeah.
if
Yeah.
it is needed, but the septals now look a lot bit more. It looks to me that
That
they're
septal
coming,
is,
they're coming from the top branch rather
Yeah.
than
Yeah.
the,
Yeah. Yeah.
than
Yeah.
the
Bottom
BA
one. Yeah.
itself,
Yeah.
the branch of that top branch. So, at least now with this big artery, you've got a lot of BE as well as that branch.
Okay. Yeah. Just look at the ostium, Leo, please.
No, actually, the wire's out.
Yeah. Yeah.
It's really that's right.
Ah. Yeah. 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 Yeah.
So the guys.
Yeah. Okay. All right. Check. Make sure that
Yeah,
ostium.
but I think,
Okay.
this
Ready?
they-
Take a
they-
picture.
that does-
Last picture. Yeah.
These pilates can be approached differently.
Yeah.
And maybe that's the
Yeah.
problem we could have done at the
Correct.
beginning.
Yeah.
We invested a little bit of time.
Yeah.
Nonetheless, so the area before the stent
Also has got a little bit of issue. Yeah. Yeah. Yeah.
that's
Yeah. We'll let it heal. Come back. Fight another day.
That's probably.
Yeah.
That's it. Sometimes knowing when to stop is the most significant.
Important thing, yeah, yeah,
We've
yeah.
tried multiple things.
Exactly.
It's one of these
Yeah.
cases that.
So just to give a brief summary, we tried, initially going retrograde, from the right coronary artery was difficult, because of the stent under expansion. Then we tried antegrade IVUS to try to identify where the origin of the LAD was. It was again proving to be difficult. Then we used our third approach, to go through the diagonal and then identify the collaterals coming from the diagonal, and then with great difficulty wiring was done up to the point of the septal branches, from the LAD, but beyond that, the proximal connection could not be made, and there was no space for us to do some antegrade dissection re-entry work. So at that point, we actually decided, safety was of paramount importance. So we came back, did the IVUS run on the RCA. The stent was grossly malapose, that was corrected based on the IVUS dimensions, and then we identified that the proximal RCA was significant, and then that means doing so another additional stent in the right coronary artery was done. And hopefully, once things settle down, we would come back and have another look, see whether we could get through the septal collaterals coming from the right. So thank you very much, Dr.
Pleasure.
Manek.
I mean, it is one of these. You have to be judicious and you have to be
Absolutely.
pragmatic, safe approach and efficient ends.
it's
Being
okay.
about efficiency
Yeah.
and about safety, and that's
Yeah.
the most. So choose the most safest approach, and then slowly ramp it up. And sometimes things might not turn to be as you think. We were
Yeah.
very close yet very far.
Yeah. Okay. Yeah. Wise. 035. Yeah. Thanks. මේ පැත්තේ රෙඩි කරන හොඳයි නේ මේ කැල්සියම් කරලා තියෙනවා so better to yeah okay right okay so we'll close the case and then we'll discuss the next case in a little bit in another 5-10 minutes time okay hopefully
She probably needs to go and lie down. Right?
sister yeah